Okay. Uh, let's celebrate this Monday on a good note by discussing another concept-based topic of medicine, that is endocrinology. In endocrinology, it's even as easier as neurology for one reason: it's all connected to physiology. Like in neurology, we discuss the anatomy, we discuss the physiology, and then we go to neurology, like that pattern. But in endocrine, it's physiology and then medicine. Okay. Now we'll discuss the glands in the body. Just to listen to me, don't write it down. It's nothing to write about. Like in a gland, if you decide the endocrine glands, one gland is above the kidney, that is known as suprarenal or adrenal, that produces cortisol, aldosterone, sex hormones, and within the body, epinephrine and non-epinephrine deep inside. If you go above in the pancreas, you got a beta cell that is producing insulin. And you go above, you have a thyroid gland. There must be some voice quality problem at your center, Allahabad and Aurangabad, and rest of the centers are okay with it. Continue. There's a thyroid gland that produces T4 and then converts itself into T3, and the boss of all, that is a pituitary gland. Pituitary gland is a gland that regulates every gland below which I have talked about, except for the beta cell in pancreas. And above the pituitary gland, there is also hypothalamus, the big boss. Okay. So we'll start with the pituitary gland and the problems related to it. We'll start with the anterior pituitary first. We'll start with a very important hormone in that pituitary gland that is seen in the anterior pituitary, known as prolactin. Prolactin. Prolactin is produced very often in the anterior pituitary by a group of cells that we know as lactotroph cells. Lactotroph cells produce anterior pituitary, lactotroph cell produce prolactin hormone. Now we understand that the word is prolactin because the main function that prolactin basically performs, it induces and maintains the process of lactation. So lactation, that is milk production in the breast tissue, starts and is maintained by the process, by the effort made by prolactin hormone. Secondly, it also has a capacity to inhibit the bleeding phase of the menstrual cycle, that is known as menstruation. That's one good reason that in a female who is lactating, she is not menstruating. At the point when the female is lactating, she is having amenorrhea, that is after childbirth, that we all know as a word lactational amenorrhea. Why such a thing happens? Something from physiology again. Estrogen has got a power of stimulating the lactotroph cells and causing the hyperplasia in the anterior pituitary. As a result, there is more prolactin postpartum, that is after pregnancy. At the same time, she is not bleeding because the rise of prolactin can inhibit the menstrual process. Amenorrhea, lactational amenorrhea. Number 3, in the male population, if I try to look at, it has a possibility of inhibiting the gonadal steroidogenesis. Like in males specifically, testosterone. Testosterone in males are inhibited by prolactin hormone. So we know that from this discussion from physiology that prolactin is not well required in a female population all throughout her life. She requires it more in amount only in a stage when she is supposed to lactate, postpartum. A male definitely doesn't require a prolactin. So that message of control of prolactin release comes from hypothalamus. There is a hypothalamus that is able to inhibit the prolactin release and formation by an inhibition that comes down, known as dopamine. So dopamine inhibits the prolactin formation and release all throughout the time. Now if I look at the disorder hyperprolactinemia, that is a rise of prolactin that you see physiologically or maybe pathologically, what can be the possible cause for that? Etiology. Number one could have been a drug. Drugs, I believe, which are blocking the central dopamine receptors, dopaminergic antagonist. A good healthy example that we know from the psychiatry textbook are typical antipsychotics. And the second one is an antiemetic, that is metoclopramide. We know that one more drug, just to remember the name, dopamine depleter. Dopamine depleters are one of them, a very famous example, methyl dopa. So two groups of drug, one is dopaminergic antagonist and other one a dopamine depleter, can cause hyperprolactinemia, because if they block the dopamine effect on the pituitary gland, they cause uninhibited rise of prolactin. Number two, we find that the prolactin finds its way out from the body via the kidney tissue. So if the patient is having renal failure, there is impaired excretion of the prolactin. As a result, patient might have a hyperprolactinemia. Number three cause, more important cause, it would have been a growth inside the pituitary gland. Number three cause, which is known as pituitary adenoma. But the thing is that the pituitary adenoma can do anything at all. It can produce ACTH, can cause Cushing syndrome, it can produce growth hormone, it can cause acromegaly, it can produce TSH, can cause hyperthyroidism. But I want to say it only produces prolactin. So prolactinoma is the name. The textbook tells me that most of the pituitary adenomas are asymptomatic. If at all they become symptomatic, it is a prolactinoma. So most common type of a pituitary adenoma that you possibly see is a prolactinoma. Okay. Now if I divide a pituitary adenoma or prolactinoma, I divide it very often on a size. If the size is less than or equal to 10 mm, it is known as a microadenoma. If the size is actually more than 10 mm, it is known as a macroadenoma. We should note this fact that radiologically, histologically, 90% of the pituitary adenomas are micro, while 10% are macro. So a micro are always more common than macroadenomas, radiologically, clinically. Okay. One question at this point, interesting question from AIMS. Pituitary macro adenoma refers to size of tumor how much? 1 centimeter, 10 centimeter, 0.1 centimeter, or 10 meter. Oh, that's too big. Pituitary macroadenoma refers to size of the tumor how much? More than, refers to size of the tumor more than it's a very simple question here. Maths question. See? Arey yaar. Simple thing. 10 millimeter is equal to 1 centimeter, my dear friend. Common sense. So answer is 1 centimeter. Okay, not 0.1 centimeter. 1 centimeter is equal to 10 millimeter. Common sense. Okay, so answer is 1 centimeter. Okay, fine. Now If I look at the clinical features of prolactinoma, there is more production of the milk in the breast tissue that is known by the term galactoria. There is inhibition of the bleeding phase in the menstrual cycle that is known by the term amenorrhea. There is inhibition of gonadal steroidogenesis like testosterone. As a result, there is loss of libido, loss of sexual drive, loss of libido, and everything with amenorrhea, loss of sexual drive, ends at one point, that is known as infertility. Very often in clinical description, it is known as galactoria-amenorrhea syndrome, and the most common symptom that you see in patients with any hyperprolactinemia disorder like prolactinoma is galactoria. If I look at this thing, this all is an endocrine abnormality. Okay, so galactoria-amenorrhea syndrome is a well-known name for the prolactinoma, and the most common endocrine abnormality that the patient faces is galactoria. If I look at the problem more expansile, like if I see the pituitary gland, it sits in a cave in the skull known as sella turcica. Due to some reason, the pituitary gland grows up in size. It has a capacity not to dissolve the sella turcica, but can easily compress someone on the top part, that is known as optic chiasma. If it compresses the optic chiasma, one of the symptoms that the patient might have is this homonymous heminopia, also known as bitemporal heminopia. So this happens to be one of the compressive symptoms of this disorder, prolactinoma. Compressive symptoms are often seen in patients with macroadenoma as compared to microadenoma. Okay, so compressive symptoms are more often seen in a macro as compared to a microadenoma. So as a symptomatic thing that we need to know, a female who comes with galactoria-amenorrhea can have other causes of that problem as well. So if the patient is having hyperprolactinemia or not, the first step that we take is estimation of serum prolactin. Serum prolactin. Normal serum prolactin in a range, if I recall, is 5 to 25 microgram per liter. Okay. The book says if the serum prolactin goes beyond 200, then in that case you need to press the panic button and you need to see the pituitary gland, that is a soft tissue imaging done very often with an MRI. Okay. On doing an MRI, I am wiser enough. I know it is a prolactinoma, number one, and I secondly can classify it on the size. Less than equal to 10 mm, microadenoma, more than 10 mm, macroadenoma. Now for treatment of such a patient, it's always easy. If you recall from physiology, hypothalamus inhibits the prolactin release and formation by an inhibition that comes down molecule dopamine. So I start feeding the patient with a drug which is dopaminergic in nature, which acts like dopamine and inhibits the prolactin release. In a microadenoma, I start my therapy with a dopaminergic agonist. A good example, short-acting congener, bromocriptine, and a long-acting congener, once a week, cabergoline. Now you continue therapy maybe for 1 or 2 months and then determine the serum prolactin. If I see the serum prolactin is less than 25, all is well. Continue same treatment, CST. Continue same treatment, CST, abbreviation. If the serum prolactin ranges in a range of 25 to 50, then it will be better. I increase the dose of the drug. If it is more than 50, then I press the panic button. I remove the pituitary gland by doing a surgery. Surgery in this case is not craniotomy that you routinely do, removing the skull, removing the brain. No. You take the patient under image intensifier. You see the sphenoidal sinus there. You take a gun with a camera attached, endoscopic gun, and you approach the pituitary gland across the sphenoidal sinus and take it out. Transsphenoidal resection. So the surgery of choice is transsphenoidal resection. Now the thing for microadenoma is quite simple, it's medical. Even for macroadenoma, it's always simple, it is always medical. Don't worry, it's a larger size tumor, no one dies of prolactinoma, number one thing. Clinical thing, no one dies of prolactinoma, so there is no threat to life, so there is no urgency in doing a surgery. And secondly, if I remove someone's pituitary gland out, I don't remove the pituitary gland, I remove the life of the patient out. I remove the TSH, ACTH, ADH and all the things. So it becomes more of a problem because of hormone replacement that the patient requires lifelong rather than a good healthy solution. And this is by clinical interest and nature, and by all the trials that they have done, they have seen that patients with even macroadenoma will respond to medical treatment very well. Okay, so don't worry, all is well. Even with a macroadenoma, you start your therapy with a dopaminergic agonist, and then you wait for somewhere 4 months. At an interval of 4 months, you get an MRI done, and you look upon the size of the tumor. If size of the tumor regresses, all is well, continue same treatment, CST. If the size is U, I am using this abbreviation U as unchanged, then in that case you go in for a surgery. Okay, so moral of the story which I recall is that even if the treatment is for macro or micro, the treatment of choice is always the medical first. Okay, please put a tick on cabergoline. For one good reason, drug of choice for prolactinoma, something that is somewhere discussed in gynae, is bromocriptine. No. Recent change in Harrison is cabergoline. Cabergoline is a long-acting congener. Bromocriptine is a short-acting congener. You know, this dopaminergic agonist can cause one side effect very commonly, nausea. Remember, migraine I have taught you. Dopaminergic theory. Dopamine stimulation, nausea. That's why you give metoclopramide there. This time, dopaminergic agonist, more nausea. A shorter acting, faster acting bromocriptine will cause a lot of nausea in the patient. That's why we consider using cabergoline in the patient. Okay. And they've seen this in trial for the last 5 years at least, that patients with cabergoline are more responsive as compared to bromocriptine. Now, I imagine if the patient is having a visual defect, bitemporal hemianopia, still the treatment is always medical. Don't worry, all is well again. Surgery done as per this protocol, and surgery done for patients with visual defect who are not responding to medical treatment. Okay, so even for the visual defect bitemporal hemianopia patient, the treatment should always be medical first, not jump to surgical so very often. Write down one question on this. A 35-year-old female with galactorrhea, amenorrhea. MRI shows a pituitary gland or a pituitary adenoma of 15 mm size. Treatment: cabergoline, radio frequency ablation, TSR, transsphenoidal resection, or metoclopramide. What's your answer for this one? A female 35-year-old galactorrhea amenorrhea pituitary band shows a size 15 mm. Simple. Okay. Rhythm correct. Amenorrhea, galactorrhea, prolactinoma, and you diagnose it with MRI. Even with a macro, start with medical first. So don't worry. If I just change the slight language of the question, it is 35 mm and with bitemporal hemianopia. Then what is the treatment? Still A or C? Still A. Reason? Even for a visual defect patient, you start your therapy with medical first. If the patient doesn't respond, then we go in for a surgical treatment. Now the thing is that if a female is in a fertile age group, maybe she's in a fertile age group of 20 to 40, she is having prolactinoma, she is having amenorrhea. That's one reason she cannot conceive. She is having infertility. Now the female desires to conceive a known case of prolactinoma on a dopaminergic agonist. Now the clinical problem that we face is that these dopaminergic agonists are very good drug, but they have a potential of having teratogenicity. That is, during pregnancy, they can be teratogenic. So there is a consensus document on this funda, like how to manage a female who is a known case of prolactinoma and she is on a dopaminergic agonist therapy. Okay, write it down. Patient is a known case of prolactinoma and she is a female in a bracket of 20 to 40 years age, fertile age group, and she desires to conceive. What should be done? The book says allow first 3 normal menstrual cycles. 3 normal menstrual cycles are to be done for the patient so that a healthy endometrium grows inside the uterus and it can implant the embryo very well. Then it is always better to discontinue the dopaminergic agonist that you are giving to the patient. For one reason, if a female conceives after a long gap, a case of infertility conceives after a long gap, in clinical sense it's a precious pregnancy. So don't try to waste the fetus inside by some drug which may turn out to be teratogenic. Okay? And then allow her to conceive pregnancy. Now during pregnancy, you need to see the patient very often. Assessment. Assessment with serum prolactin is never considered. For one reason, a rise of serum prolactin that you see in pregnancy is actually a physiological rise. So you see very often females in pregnant state coming with a serum prolactin value of 300, 400 even. Most of the time it is even more than 200. So don't panic. Rise of prolactin is physiological during pregnancy. It is never pathologically differentiated from the physiological rise. Assessment, I believe, could be done by something which is non-invasive known as visual perimetry. We look at the bitemporal heminopia in the patient and then we are able to see that through visual perimetry. And if the vision is impaired by any chance, I say the size of the tumor prior to pregnancy was 5 mm. Now it went up to 15 mm, it became 25 mm, and that is causing bitemporal heminopia due to optic chiasma compression from below. If the patient is having visual defect, then in that case transsphenoidal dissection is considered for the patient somewhere in the second trimester. But the thing is that this visual defect and all is not very common. It's rare to happen in a patient with prolactinoma during pregnancy. So all is well, don't worry. A female desires to conceive a known case of prolactinoma. She can carry on her pregnancy without treatment. There is not big threat to the patient. One reason why I believe, if I look at the patient's symptoms, galactorrhea, amenorrhea, something which happens in a patient with prolactinoma, earliest and most common, they are seen in pregnancy also. Galactorrhea can happen in pregnancy. Amenorrhea is obviously happening in pregnancy. You don't rely on symptom. You don't rely on serum prolactin. You can rely on this visual perimetry. Okay. Write down one question on this. True about prolactinoma in pregnancy are all except. True about prolactinoma in pregnancy are all except. Most common tumors in pregnancy and are usually asymptomatic. Option B. Size of tumor increases in pregnancy. Increasing prolactin level indicate bad prognosis and requires monitoring. Option D. In macroadenomas of 1 centimeter may lead to vision defect. True about prolactinoma in pregnancy are all except most common tumors in pregnancy and are usually asymptomatic. Size of the tumor increases in pregnancy. Rise of prolactin means bad prognosis, required to monitor it. Good, I understand you understand the topic. I don't have a reference for this one, most common tumors in pregnancy. Not very often. But in pregnancy, if I look at the symptom of prolactinoma, galactonia menorrhea, they're seen in pregnancy. With reference to a pregnancy, they are asymptomatic, correct. Size of the tumor increases in pregnancy. Estrogen can have a proliferative effect, yes, but it doesn't exceed 10 mm, doesn't exceed 35 mm to cause a visual defect. In macroadenoma, 1 centimeter may lead to a visual defect. That is even true without pregnancy. Even in pregnancy, that's a correct statement. But rise of prolactin level is remaining bad prognosis and you require to monitor the prolactin? No. We never decide a prolactinoma as micro or macro on a prolactin level. Okay, one thing. And a rise of prolactin that you see in a patient would be physiological during pregnancy rather than pathological. Okay. Now we'll consider the discussion on another important hormone in the anterior pituitary, one of the very interesting hormone, growth hormone. Growth hormone. Growth hormone is actually produced in the anterior pituitary gland by a group of cells that we know as somatotroph cells. So the group of cells in the anterior pituitary which are known as somatotroph cell, they will produce growth hormone. A rise of growth hormone that we see in clinical practice can often be physiological rise. Okay, so we see a rise of growth hormone very often as a physiological rise. Something to know that, one question from physiology, most abundant cell in the anterior pituitary are somatotroph cells. Most abundant cells in the anterior pituitary are known as somatotroph cells. Rise of growth hormone, very often we understand, is physiological. One reason to have a rise of growth hormone is exercise. Second reason is sleep. And the third reason is fasting. So these are the three important physiological stimulation things to rise the growth hormone level in the body. Now, it becomes a trouble. Like most of us are sleeping in the class, most of us are empty stomach, and most of us are moving the hand. They were exercising. So I believe after my class your growth hormone will rise physiologically, and you all will grow 2 or 3 feet taller at the end of my class. That doesn't happen very often. For one reason, a rise of growth hormone is physiological, but it's not a big threat to the patient. Because growth hormone is taken to the liver. In the liver there are a group of cells which are known as somatomedin cell. They produce an intermediate substance, insulin-like growth factor 1, IGF-1, that happily acts on the bone and happily acts on the soft tissue. So we have got an IGF-1 molecule that acts on the bone and the soft tissue. So moral of the story is that growth hormone doesn't act on the peripheral tissue directly. It acts through an intermediate metabolite, IGF-1. I believe a rise of growth hormone, not a big threat to me, but a rise of IGF-1, a bigger threat to me. Okay. So now we understand that there has been a disease in which we see a rise of growth hormone as per the epiphyseal fusion. Before epiphyseal fusion, if there is excess of growth hormone, that can cause the bone to increase in height very often. That is known as gigantism. A patient will gain a lot of height. It looks like a giant, known as gigantism. After epiphyseal fusion, Sometimes the height of the patient cannot increase because the epiphyseal fusion has already occurred. The digits will become large. Rise in the size of the digit is known by the term acromegaly. So there are two things to remember: gigantism and acromegaly disorders. Now whatever the symptom, whatever the disease that you are seeing in the patient, clinical features. Very often tall stature. They look very tall. They've got a large digits also, and they've got a protrusion of the jaw that you see known as prognathism. You see the protrusion of the jaw very often, that is known by the term prognathism. So if I see a man who is very tall, who has got a very large digits and has got a protruded jaw, a very famous personality that you see him fighting in WWF arena, who is he? Tell me an answer, general knowledge question. A man who is very tall, large digits and a prognathism. Oh, good. Khali, Punjabi wrestler Khali. A living legend again with the disorder may be gigantism. Since his childhood days he was having a pituitary adenoma. That pituitary adenoma is something that is causing a rise of growth hormone, rise of IGF-1. That's possibly a reason that he gained a lot of height and his hands and prognathism appeared on his face. It gave me a good benefit. He could fight very well. But for last 2-3 years he is not seen in the fighting arena because this acromegaly can be a bigger threat to the patient. How? Soft tissue proliferation, if I look on the neck, can obstruct the airway passage during sleep, causing obstructive sleep apnea. Soft tissue proliferation on the heart can dilate the heart, causing cardiomyopathy. Soft tissue proliferation can cause insulin resistance, resulting in diabetes. Okay, so we remember that in a patient with acromegaly, all is not well. Patient can have obstructive sleep apnea known as OSA. Patient can have cardiomyopathy. Patient can have diabetes mellitus. All three are silent killers that a patient can have. Okay. So apart from the routine features of clinical appearance, they can have a certain pathological problem in the body. So all is not well in these patients, we remember that. Okay. Now investigation. If I want to investigate the patient of acromegaly or maybe gigantism, I may end up getting this growth hormone level done, growth hormone assay. Okay, growth hormone assay. Growth hormone assay is not a very good test for one reason. Growth hormone goes up and down all throughout the day like this. You catch him here, you think it's a Kali. You catch him here, you think it's a Dov. So it becomes a problem. Growth hormone goes up and down all throughout the day like this. So growth hormone assay is not a reliable marker because this up and down nature of growth hormone level is physiological. Okay. Better answer for diagnosing this disorder is IGF-1 assay. The best screening test that you need to do for the patient is IGF-1 assay. The first test that you can advise to the patient to be done to diagnose it as a case of acromegaly is IGF-1 assay. Okay. Number 3, growth hormone is inversely proportional to glucose. Okay, growth hormone is inversely proportional to glucose. Growth hormone is inversely proportional to glucose. So what do? Normal subject, we give him 75 gram of glucose. If I increase the glucose load to a normal subject, the growth hormone will come down. come down for one reason: growth hormone is inversely proportional to glucose. Okay, fine. I'll repeat from the investigation part from the very beginning. If I see a tall man who is very tall, who is having large digits, large foot and all, I get the growth hormone assay done. That's a wrong thing to be done for one reason: growth hormone goes physiologically up and down all throughout the day like this. I do a growth hormone assay at this point, it's high. This high is a physiological high. This low is a physiological low. Okay. So I cannot pinpoint at a level of growth hormone and tell him that he is a case of acromegaly or dwarfism. So it's not very easy to do that. So best test would be an IGF-1 assay. For one reason, a rise of growth hormone is not very hazardous until a IGF-1 assay or IGF-1 level rises. A rise of IGF-1 will cause in the rise in the soft tissue and the bone growth. So IGF-1 assay is the best screening test that you can recommend for the patient to be done. Another formula, very hit formula: growth hormone is inversely proportional to glucose. If I give 75 gram glucose to a normal subject, then in that case growth hormone level will come down. But in a patient who is having acromegaly, growth hormone level will often be unchanged or U. For one reason, they are harboring a pituitary adenoma. Okay, so that pituitary adenoma doesn't listen to this kind of a thing. The growth hormone level is often unchanged. This kind of a test is very well known as a growth hormone suppression test. Ideally, giving 75 gram glucose will be a thing that will talk in diabetes as a glucose tolerance test. It's not a glucose tolerance test, it's a growth hormone suppression test. This test is known in the book as a confirmatory test for diagnosis of acromegaly. So confirmatory test for diagnosis of acromegaly is growth hormone suppression test. Number 4 is a radiological test that is known as heel pad thickness. Normally, if I look at the foot of a normal subject, the bone is quite near to the sole of the foot like this. This is normal. But in a patient who is having acromegaly, they are having a soft tissue proliferation, and as a result the heel pad thickness will possibly increase. Okay, so there is a rise of the heel pad thickness in a patient who is having acromegaly. So one of the radiological tests that you can recommend to the patient for diagnosis of acromegaly is a heel pad thickness. Treatment primarily is surgery for one good reason or one bad reason. All is not well for the patient. Okay, so we know that a patient of acromegaly might lose his life due to cardiomyopathy, obstructive sleep apnea, or maybe diabetes. So the treatment of choice is always the surgery, that is obviously a transsphenoidal resection, TSR. But the problem is that the most abundant cells in the anterior pituitary are somatotroph cell. So if you remove the pituitary gland, you might leave some somatotroph behind. So we need to add some drug which is known as adjuvant therapy. Drugs possibly which will block the central growth hormone action, growth hormone antagonist. Two drugs in this choice are octreotide and the second one is pegvisomant. So octreotide and pegvisomant are the two drugs which are growth hormone antagonists that are added to the surgery, adjuvant therapy. Okay, so treatment of choice for acromegaly is always a surgery. It is not a medical treatment. Okay, so that's easy to discuss hormone, nothing much to be read about it, growth hormone, and easy to discuss hormone, growth hormone. Now something more concept based, something that is interesting is from the posterior pituitary that we know as ADH, anti-diuretic hormone. Anti-diuretic hormone, also known in my physiology book as vasopressin. So anti-diuretic hormone ADH or vasopressin. First, the physiological aspect. something that ADH helps me to survive in a climate when I don't get water. See, in physiology practice, if you see, you don't drink water, you don't produce urine. It's an effort made by ADH. You don't produce urine so that you can conserve the water in your body. There's an ADH, antidiuretic hormone, that often is coming out from the posterior pituitary gland by a response of dehydration. So in a process of dehydration, ADH comes out, antidiuretic hormone, that acts on the kidney, the last terminal part, collecting duct part, and it happily reabsorbs the water. So what happens? ADH or vasopressin acts on the last terminal collecting duct part of the kidney, it reabsorbs the water. So in that sense, you are able to so kidney collecting duct part, it will reabsorb water. So in that sense, you'll conserve water. So whatever the water you're going to lose out in the urine, you are able to retain back in the body by conservation phenomena, antidiuretic hormone or ADH. Okay. Now, as a result, you don't drink water, you don't produce urine, an effort made by ADH. Now, something goes wrong maybe. If the ADH is not getting formed, there is a deficiency of ADH, or possibly the ADH is unable to act on the kidney, resistance to ADH. What will happen? Every drop of water that comes out in the collecting duct part will come out. So the patient will lose a lot of water in the urine, that will possibly increase the urine output, polyuria. It will have more water in the urine. As a result, there is decrease in the urine osmolality, and you lose a lot of water from the body. As a result, there is increase in the serum osmolality. This thing or this drama is very famous, known as diabetes insipidus. So DI, a very famous disease in which the patient loses a lot of water in the urine, causing a high urine output with a hypoosmolar urine, with a hyperosmolar blood or the serum, because the ADH formation or action is at fault. That is known as diabetes insipidus. Okay. Now, before going into the topic proper, let's see the hormone, antidiuretic hormone or vasopressin. ADH or vasopressin is able to act on the body via two kinds of receptors. One is a V1 and the other one is a V2 receptor. V1 receptor is very often seen on the blood vessels, and on the blood vessels it is causing vasoconstriction. It is constricting the vessel that is supposed to get dilated. You know, one reference for this I'll give you: portal hypertension, patient having esophageal varices, lower esophageal sphincter, see the dilated tortuous vessel that may suddenly rupture, bring a blood in the oral cavity, upper GI bleed or hematemesis. For dealing that patient, you give endoscopy, you do sclerotherapy, you give octreotide, somatostatin, and you can also give this vasopressin. Okay, so I believe that a patient who is having a bleeding esophageal varices can have a benefit by using this ADH or vasopressin drug. So in patients with bleeding esophageal varices, it can easily constrict the vessel, it can stop the bleeding, vasoconstriction. V1 receptor is also seen on the smooth muscles which I see on the intestine. As a result, contraction of smooth muscle can occur. V2 receptor, more important for my life. Why? V2 receptor is seen in a patient on the kidney, the last terminal part, collecting duct part. So if the patient is having deficiency of ADH, diabetes insipidus, I give him ADH, the action is via V2 receptor. And more common than this, nocturnal enuresis, nighttime bedwetting, nocturnal enuresis, in which the patient does bedwetting during sleep, nocturnal, during sleep. Now what happens for treatment of such a patient, nocturnal enuresis? You stop the water intake beyond one time, you put an alarm clock, wake the patient up. That is all non-pharmacological technique. One of the pharmacological technique is giving ADH or vasopressin to the patient. You give ADH or vasopressin, that acts on the collecting duct, that reabsorbs the water. So there is no water in the collecting duct, there is no nocturnal enuresis that you possibly see. So while dealing with a patient with nocturnal enuresis, action of ADH or vasopressin is via V2 receptor. V2 receptor is also seen on the vascular endothelium. On the vascular endothelium, it often produces this, a coagulation cascade molecule, von Willebrand factor. So if the patient is having deficiency of this von Willebrand factor, von Willebrand disease, you give him ADH or vasopressin, patient will have a benefit. Okay. I'll give you one question at this point. Write it down. A vasopressin analog does not produce therapeutic effect through V2 receptor in which of the following disease? Option A, central diabetes insipidus, bleeding esophageal varices, type 1 von Willebrand disease, primary nocturnal enuresis. A vasopressin analog does not produce a therapeutic effect through V2 receptor in which of the following disease? Tell me the answer for this. Bleeding esophageal varices. Why? Bleeding esophageal varices, the bleeding will stop via V1 present on the blood vessels. Simple answer. Okay. Now proceed. Before going any further, let's see something basic from biochemistry and physiology. What are the normal values that we see? Normal values of osmolality and electrolytes. Like if I see the normal serum osmolality or the plasma osmolality, that comes in a range of 275 to 295 milliosmol per kg. Okay. If I look at the normal urine osmolality, that happens to be seen in a range of 300 to 1000 milliosmol per liter. If I look at the normal serum sodium, it comes in a range of 135 to 145 milliequivalent per liter. If I look at the serum potassium, it comes in a range of 3.5 to 5 milliequivalent per liter. So these are the four things that you need to see: normal serum, urine, sodium and potassium. Okay, normal serum osmolality is 275 to 295, urine is 300 to 1000, sodium is 135 to 145, potassium is 3.5 to 5. This is something which we consider as a normal standard SI units. Okay. Now the patient of diabetes insipidus who comes to me in the OPD comes with a very typical symptom which is known as polyuria, a rise in the urine output that comes in a range of more than equal to 3.5 liter per day. Okay, so the polyuria is defined as a urine output of more than 3.5 liter per day. Polyuria, a normal thing? No, a abnormal thing. Now polyuria as a symptom can appear physiologically also. Like if I see in the physiology, there is a Bowman's capsule, there is a loop of Henle. Before the loop of Henle, there is a proximal convoluted tubule, loop of Henle and a collecting duct. We understand by a thickness or high osmolality in the GFR, certain solutes can come into this collecting duct part. I understand from physiology again, 90% of reabsorption occurs in the collecting duct. So that 90% will just remain 9% for one reason. Water always moves from a dilute to a concentrated gradient, from a hypo to a hypertonic gradient. So as a solute particle, if I see, it can drag the water along the course because it can shift water across this membrane. This process is known as osmosis. So there is a possibility there are certain solutes by the process of osmosis can drag the water along the course, solute or osmotic diuresis. Okay, fine. Three solute particles very often to be remembered. One is glucose. Yes, our clinical reference on this. Renal threshold for glycosuria is 180. Yes. Beyond 200 is diabetes. A diabetic patient often complains of polyuria. Now why polyuria occurs in diabetes? We know the answer. Another molecule, that is mannitol. A very famous one, osmotic diuretic to decrease the raised ICT. And number 3, hypercalcemia. So these are 3 important solute particles by the process of osmosis can drag the water along the course, causing solute or osmotic diuresis. Now the thing is that a solute comes in to increase the urine osmolality. Water comes in to balance it. Water doesn't take the urine osmolality down. It doesn't even dilute the urine so well. It just balances this. So from a high urine osmolality, it becomes slightly on a normal range. So we understand that the urine osmolality in a patient with solute or osmotic diuresis comes in a range of more than 300. The normal range of urine osmolality, just to revise that part, is 300 to 1000. It may be 1000, it may be 1100, yes, but it is not less than 300. It's not low. Now if I see a patient who is having a low urine osmolality, that is urine osmolality less than 250, okay, then I see a possibility that the patient possibly is not able to form ADH, or the ADH that is formed is unable to act on the collecting duct. So there is a possibility that there is no reabsorption of water. Every water molecule that comes to the collecting duct is just washed off in the urine. Patient will have a high urine output with the dilute urine, diabetes insipidus. More common than diabetes insipidus, which I see as a disorder, can be you and me even. Under stress, we drink more water, we produce large amount of urine, which we know as a term psychogenic polydipsia. So it is a problem which is psychological, stress related, more water intake, more urine output, psychogenic polydipsia, a term. Now the thing is that in patients with psychogenic polydipsia, we realize that the ADH formation and action is so very perfect. They don't have any problem in ADH formation and action. And in patients with DI, they have a problem in formation and action. Now both of them are having polyuria with a low urine osmolality. Yes. Now how to differ the two things out? I can perform a very simple test, which is known as a water deprivation test. I stop the water intake for the patient, which is known as water deprivation, for maybe 6 hours, 12 hours, 15 hours, 20 hours, 25 hours. If I stop the water intake, there is dehydration that stimulates the production of ADH, action of ADH. If the production and action of ADH is perfect, what will happen? Water reabsorption will occur. Now the water doesn't remain in the urine, it remains with me in the body. As a result, the urine osmolality that was low will become normal, may become high. But this thing from low to high will come in a patient with a normal intact ADH production and action, a patient with psychogenic polydipsia, okay, but not in a patient with diabetes insipidus. So we do a water deprivation test and we check on the urine osmolality. If the urine osmolality improves, if the urine osmolality basically improves, it is a case of psychogenic polydipsia. If the urine osmolality is U, that is unchanged, it is a case of diabetes insipidus, okay, because in that patient of diabetes insipidus the production and action is at greater fault. Now a well established case of diabetes insipidus, I give him an ADH stimulation. If I give him ADH and I check the urine osmolality, and if the urine osmolality improves, what happens? That means the ADH production was at fault. You gave him ADH, he benefited. Water reabsorption. Central DI. Central DI means a patient who is having an ADH deficiency. Urine osmolality, if it is U, that is unchanged, then in that case the case is a case of nephrogenic DI, ADH resistance. So if you give ADH to a patient who is a known case of DI, if the urine osmolality improves, that means the reabsorption is occurring. Patient has a deficiency, you give him a supplement, he benefits. But if it is unchanged, it means a case of resistance to ADH, nephrogenic DI. Moral of the story is that ADH stimulation test is to differ out central DI with nephrogenic DI, while water deprivation test is to differ out psychogenic polydipsia from DI. Okay. Now the thing is that a patient with psychogenic polydipsia may not comply with a water deprivation test. They're not ready for that because they are having a psychological psychogenic problem. They don't realize they're unwell, psychosis. So what do I do? To differ out the two, I understand that a patient with DI loses a large amount of water in the urine. As a result, serum osmolality is high and a serum sodium value is also high along with that. But in a patient with psychogenic polydipsia, serum osmolality and serum sodium both are low. Because they drink more water, they produce a large amount of dilute urine, but at the end of the day, they retain some water in the body. That produces a slight dilution phenomena that decreases the serum osmolality with the sodium value. Psychogenic polydipsia patient. Okay. I'll revise everything with you guys again. If a patient comes to me with high urine output, polyuria, more than 3.5 liter in 24 hours duration, I look on the urine osmolality. If it is in a normal range above 300, I put the blame on the solute. By the process of osmosis, glucose, mannitol and hypercalcemic states can drag the water along the course. If I took at the patient with a low urine osmolality less than 250, it is possibly a case of ADH deficiency or resistance, diabetes insipidus, or maybe large amount of water intake, psychogenic polydipsia. To differ out the two, I perform a water deprivation test. Urine osmolality if improves on doing a water deprivation, it is a case of psychogenic polydipsia. If the urine osmolality is unchanged, it is a case of diabetes insipidus. Now if a known case of DI is taken up for this ADH stimulation test and the urine osmolality is seen to improve, that means the patient had deficiency, you give him supplement that will improve central DI ADH deficiency. If the urine osmolality is unchanged, that is ADH resistance, nephrogenic DI. So ADH stimulation test is to differ out central from nephrogenic DI. Water deprivation test is to look out for psychogenic polydipsia with DI. Now if the urine output is high, urine osmolality is low, serum osmolality and sodium is high, it is a case of DI. If the urine output is high, urine osmolality is low, serum osmolality and sodium is low, it is a patient is very low in life, that is case of psychogenic polydipsia. Only thing high-fi is the urine output, polyuria. Chalo, we'll understand this topic well if we solve the MCQs. Write it down. Choose the best lab value for central diabetes insipidus. On the left you got urine osmolality. On the right we got a serum osmolality value. Option A 50, 300. Option B 500, 260. Option C 50, 260. Option D 500 or 100. Choose the best value for the central DI. Any ideas? A, B, C, D. Why B? I don't understand why B. A patient with central DI will have a low urine osmolarity, okay, less than 300. If you look at the options A and C, both of them are less than 300, okay. Now I have to choose a value that is above 295 serum osmolarity. That is only one value that I have is A, okay. So I have to choose a value urine osmolarity low and high serum osmolarity for central DI, that is option A. Now who is option C? Any ideas? Who is option C? Low urine osmolarity with low serum osmolarity. Who is option C? Psychogenic polydipsia. Okay. Simple answer. So I'll put you one more question for this. A 33-year-old lady with polydipsia and polyuria. Her symptoms soon started after a road traffic accident 6 months ago. Her daily urine output, per day urine output, is 6 to 8 liters per day. Her serum sodium value that they given in the question is 130 millicount per liter. Her blood urea value is 15 milligram per deciliter. Her blood sugar or the glucose value is 64 milligram per deciliter. Her plasma or the serum osmolality is 268 milliosmol per kg. Her urine osmolality is 45 milliosmol per liter. Diagnosis: option A, central DI. Option B, nephrogenic DI. Option C, resolving ATN, acute tubular necrosis. Option D, psychogenic polydipsia. A good answer on this? Rhythm correct, psychogenic polydipsia is the correct answer. Why? Because water deprivation test is not done in a patient with polyuria becomes a big trouble. For such a patient, what do? I look at the serum osmolarity that is found to be low. I look at the urine osmolarity that is very, very low. And the most important thing that I found that the serum sodium is also very low. Okay. So that's the story of everything low is psychogenic polydipsia. A blood sugar is 64. This is normal, neither low or high. This give me a clinical sense this is not a case of diabetes mellitus. Why? Because the first symptom that the patient had was polydipsia and polyuria. Okay. So it is not a case of diabetes at all. Now please tell me one thing. If you can guess it out, why a road traffic accident story is so very important. Why a road traffic accident story is important. Is something to do with the question or is this a relevant fact that they're given? Why a road traffic accident? The story started after a road traffic accident in the patient, no? What's the relevance of having road traffic accident? Yes, correctly guessed, post-traumatic stress disorder. Okay, PTSD is the word. Not myoglobin, yaar. No, no, don't think it that way. 6 months ago, now myoglobin will come out acute tubular necrosis. No, no, no. Okay. Uh, After a road traffic accident, there is always a chance of post-traumatic stress disorder that can cause psychogenic polydipsia in return. Okay. Write one more question out. A patient following head injury was admitted in ICU with signs of raised intracranial tension, raised ICT. He was put on ventilator, diuretics plus IV fluids. Question is now 24 hours later, his urine output is 3.5 liter. Serum sodium is 156 millicillion per liter. Urine osmolarity is 316 milliosmol per liter. The diagnosis that you can possibly think in this patient: option A, high output due to diuretics, diabetes insipidus. Option C, too much infusion of saline, cerebral salt wasting disease. Patient with head injury was put on ventilator with IV fluid and diuretics. 24 hours later, his urine output is 3.5, serum sodium 156, urine osmolarity is 316. What's the diagnosis? Surprise, not everyone is correct today. In AIMS, as I mentioned in the last class, the protocol is what is the answer and why it is an answer and why not the other people are the answer. Look at the question again. Patient with head injury today, 24 hours later, he comes with a polyuria 3.5 liter. His serum sodium is 156 and his urine osmolarity is 316. Fine. Now if the urine osmolarity is 316, tell me one thing. Is the 316 value normal or high or low? Write one thing. N high or low. Is the urine osmolarity 316 normal? Yes. If the urine osmolarity is more than 300, then there is one possibility of having a solute by osmotic diuresis, increasing the urine output. Possibly if I look at the question, diuretic is given. He did not mention which diuretic. In raised ICT, what diuretic I give? Osmotic diuretic, mannitol. So there is a possibility that mannitol went into the collecting duct, dragged all the water along the course by the process of osmosis, causing a polyuria syndrome. So high output due to diuretics will become the best answer. Why not the other people? Diabetes insipidus would become a best answer if the urine osmolarity was 216. It was less than 250, then only you consider the diagnosis of DI. Out. Too much infusion of normal saline. Oh my god. Doctor's fault. Easy to take, difficult to claim. I remember in clinical practice, for most of the patients I give normal saline, dextrose normal saline, ringal lactate, isolate M. All of them contain a lot of sodium. That sodium goes into the blood, but next day it doesn't happen like this, no? The patient has got polyuria, patient has got hypernatremia. No. because whatever sodium you give in, it will be adjusted very well with the aldosterone. Okay, so too much infusion of normal saline is too hypothetical at this point. Cerebral salt wasting disease, what is this? Last class I have discussed this, last to last, subarachnoid hemorrhage. Patients with cerebral salt wasting disease will have a rise of ANP and BNP. N, natriuresis. If you drive all the sodium out in the urine, what will happen? Patient will have hyponatremia with hypovolemia, hypovolemic hyponatremia, cerebral salt wasting disease. Very important. If the sodium is 156, it's high, it's not 106. Normal sodium value was 135 to 145, it's high. It's not hyponatremia. So don't consider the diagnosis of cerebral salt wasting disease. Best answer? A answer. Easy answer. But the thing is that every guide differs in the question. Every guide differs in the question. This is a question that I have given from Midit Khanna, typical guide. Now AA, atypical guide. In AA, everything remains the same except for the urine osmolarity, which is now, except for the urine osmolarity, which is read in the book as serum osmolarity of 316 milliosmol per kg or millimole per kg. Now what is your answer? A patient with head injury today, on ventilator, on IV fluid and diuretics, ends up having a urine output 24 hours later with 3.5, sodium 156 and the serum osmolarity 316. I knew this, you're going to answer it as B. Why? Diabetes insipidus. Patient has got high sodium, high serum osmolarity and a high urine output. Everything is high-fi. It is a case of DI. Half knowledge is always dangerous, my dear friend. Remember one way. This answer is still A. I'll tell you one good reason for that. Something in between the lines if you read in Harrison. Harrison mentions that in diabetes insipidus, the urine output is somewhere in a range of 5 to 6 liters. Not 3.5 liter. Number 1. So in patients with diabetes insipidus, the urine output is in a range of 5 to 6 liters. It's quite high, number 1. Secondly, if a patient comes with head injury, HI head injury, in first 24 hours, you don't see a deficiency of ADH. You see excess of ADH, that is known as SIADH. So in the patients with head injury, initial phases we get excess of ADH in the blood, more ADH, SIADH, not DI. After maybe 4 or 6 weeks, maybe minimum 2 weeks time that they claim in the book, you develop DI. So that's a very interesting thing. Look at the question again. Patient with a head injury 24 hours later. He's not talking about 24 days or 24 months later. Okay. So in a patient with head injury, initial phases due to raised ICT, there is production more of ADH. And then over a period of time, maybe 2 weeks minimum, you develop DI. So the answer is still A. I'll tell you why still A, not DI. Because DI has got a urine output of 5 to 6 liters, number 1. Number 2, the patient with head injury today, 24 hours later, will have more ADH, not less ADH. Reason number 2. And why high output due to diuretics? Very interesting. If the mannitol goes into the collecting duct, it will drag the water along the course, solute your osmotic diuretic. It will make after 24 hours less water in the body. As a result, less water, dehydration, serum osmolarity will go up, and something goes up along with it is the serum sodium with a urine output. So high output due to diuretics is always the best answer, even if you change the urine to serum osmolarity. Don't worry. Okay. Write down one more question. A 60-year-old female was having polydipsia, and we did an ADH stimulation test on her, and we found this thing: baseline and after vasopressin or after ADH. If I look at the baseline serum sodium, it is 151. Baseline serum osmolarity was 300. Baseline urine osmolarity was 150. After ADH, sodium became 142, serum osmolarity or plasma osmolarity became 290, and the urine osmolarity became 480. Okay, diagnosis. I'll give you options: central DI, psychogenic polydipsia, nephrogenic DI, and excess of ADH, SIADH, syndrome of inappropriate antidiuretic hormone, SIADH. Tell me an answer for this one. Easy question. Rhythm correct. You know the answer. Why? Because I see a jump in the urine osmolarity from 150 to 480. That means the action is normal, only the formation was a problem. Okay. Tell me one thing, why not psychogenic polydipsia? Why not B? A patient with psychogenic polydipsia will also show an improvement, no? Formation action is normal. Why not psychogenic polydipsia? Interesting. Serum sodium is 151. If the serum osmolarity was 265, if the sodium was 105, then I would have considered the diagnosis of this. That's why the reason of having this baseline value is very important to differ out psychogenic polydipsia from central AI. Okay. So this is something very easier topic. Now we'll go into the opposite direction. If at all we have got excess of ADH, syndrome of inappropriate antidiuretic hormone. The word inappropriate means excess, well known as SIADH. Syndrome of inappropriate antidiuretic hormone or SIADH. If there is more ADH in the blood, what will happen? There is more reabsorption of water. If there is more reabsorption of water, everything opposite will happen. There is less water in the urine, there is a high urine osmolarity that you see. There is more water in the body. As a result, there is low serum osmolarity. And something that comes down very often with the serum osmolarity is sodium. Why? A rise dip in sodium is because of more water in the body, which I know as the word as dilutional hyponatremia. Okay, the word is dilution. You gain more water, you dilute the plasma. As a result, relative sodium value comes down because of dilution. Now the problem is this: when I see that patient in my ward, these patients come with this hyponatremia. Listen to me first. They come with hyponatremia, 105 sodium, unconscious patient, throwing a seizure maybe. For that patient, I give him sodium, 3% saline. Next day, I expect the sodium to rise up. 3% saline is a good amount of sodium. From 105, it becomes 106. Next day, it becomes 103. The reason for such a not rising up of the sodium is one reason. Like if you want to fill a bucket of water below the tap and you keep the tap drop and drop open all throughout the night, thinking that the bucket will fill up tomorrow morning. No, doesn't happen. There's a small pore beneath the bucket through which all water will come out. There's a small pore beneath that is known as increased urinary sodium excretion. So these patients very often have got a rise in the sodium excretion more than a value of 20 millicalorie per liter. Why? Why? Interesting reason why that we'll discuss much in detail in adrenal problems. Look at this. If the volume increases due to large volume in the blood of water, yes, what will happen? Someone will come down, renin auntie, She'll pull down the aldosterone uncle. And aldosterone, we'll learn later, is a mineralocorticoid that is responsible for the sodium reabsorption. So if there is less of aldosterone, there is less of sodium reabsorption in the kidney tubules. As a result, there is more of urinary sodium excretion. So we see an indirect kind of a story seen in this patient, a rise in the urinary sodium excretion in patients with SIADH. One more thing, just to comment on this one. If you see a dip of sodium, you'll often see a rise of potassium and acidosis. But this thing doesn't happen in patients with SIADH. Very often we see that the potassium and bicarb level is normal. So these patients don't have hyperkalemia. They don't have alkalosis or acidosis. Hyperkalemia, alkalosis, acidosis with sodium potassium going up and down is often seen in patients with adrenal problem, not in this kind of a patient. And Harrison mentions, in spite of all the water getting reabsorbed, they don't have edema in the patient. Euvolemia is seen. So these patients don't have a retention of water leading on to edema or overhydration. Most of the time they have euvolemia. A reason for that is still a query, unknown reason that the book claims maybe. There are various factors that may cause euvolemia, but these patients are having euvolemic hyponatremia. Okay, so in SIADH patients, they have got euvolemia with hyponatremia. So the word that we use for them is euvolemic hyponatremia. Now for diagnosis purpose, to confirm the disorder, we take the help of this test. A very simple test, water loading test. Prior to this diabetes insipidus, we have done a water deprivation test. This time I give the water to the patient. Like I'll give you one reference for this. I give you somewhere 2 liters of water to drink, intake of 2 liters. Next 24 hours, our urine output that will come out is somewhere 1500 ml, 1.5 liter, normal. But in a patient who is having more of ADH in the blood, what will happen? That will easily act on the collecting duct, that will reabsorb more water. So there is less of water in the patient in the urine. So these patients don't have oliguria as such as a symptom, but as compared to a normal subject, the urine output is less because the ADH has caused the reabsorption of water. So they don't lose a lot of water in the urine. Okay, so urine output on a comparative note is less. So that is the funda of doing this test, water loading test. Now, treatment wise, what I can do for the patient is, I can at least restrict the water intake, what is known as a water restriction. If I restrict the water intake, what will happen? Less water in the collecting duct, less reabsorption of water, less dilution, less hyponatremia. So the main problem with the patient visits me is hyponatremia. That problem can be solved. So the first step that you take in treatment of such a patient is water restriction. But the thing is that water restriction is very easy to tell, difficult to follow. In a summer climate, how can you tell the patient not to drink more than half a liter? Becomes a problem. So we have got some good drugs with us which are actually inhibiting the action of ADH on the collecting duct. ADH antagonist. One of the old drug is a tetracycline analog, demicocycline, and second one a newer drug, Vaptans. If you read the older edition of Harrison, he mentions demicocycline is drug of choice. 18th edition Harrison doesn't give anything about this story. But what we read in the journal articles recently was an update that drug of choice nowadays are Vaptans. They found that demicocycline was good, but it's very not frequently available. Vaptans are made available very often in the market, and they are now become the drug of choice. So there has been a changeover in this principle. The drug of choice is no more demicocycline, it is Vaptans, like tolivaptan, conivaptan, all these Vaptan group of drugs. So moral of the story, TOC is not the DOC. TOC is water restriction. Drug of choice is Vaptan. These patients have got euvolemic hyponatremia with a high urine osmolarity, low serum osmolarity, low sodium and increased urinary sodium excretion. Okay, with a normal potassium and bicarb level. So write down one question on this. all of the following are true about SIADH except. All of the following are true about SIADH except option A. Vaptans are approved by FDA. Option B. Water loading test can be done for diagnosis of SIADH. Option C. Urinary sodium value is low or normal in these patients. Option D. These patients have got low serum sodium, hyponatremia. Which of the following is incorrect about SIADH? A quick answer on this. Easy one. Urinary sodium value is often high in these patients. It's not low and normal. Okay. Now, just to explain this funda of hyponatremia, see, in clinical practice, we divide hyponatremia on the volume status. Like we have a disease which is known as hypovolemic hyponatremia. A reference again, ANP and BNP. Natriuresis, that will excrete the sodium out of the body and will excrete the water, hypovolemic hyponatremia. What do we know this as? Cerebral salt wasting disease. Okay. Another brother of this is euvolemic hyponatremia, SIADH. Okay. And the third brother that I see very often in my clinical practice is hypervolemic hyponatremia. Hypervolemia means more water in the body. Why more water in the body? Because the patient had congestive cardiac failure, patient had nephrotic syndrome, edema, patient had chronic kidney disease, edema. So there can be more causes of this hypervolemia. So in patients even with CLD, chronic liver disease, they have a protein deficiency in the body, hypoalbuminemia causing edema. So CCF, nephrotic syndrome, CKD and CLD, these patients have got hypervolemia and they have got hyponatremia. So because of hypervolemia there is dilution. As a result these patients have got hyponatremia. Euvolemia, hyponatremia, SIADH, hypovolemic hyponatremia, cerebral salt wasting disease. So this is how we divide the hyponatremia into hypovolemic, euvolemic and hypervolemic. Very simple funda. Any doubts on this one, this topic? See, I believe this diabetes insipidus and SIADH are something very poorly given in Harrison. You don't understand what is it, why it is, and what is the treatment. He doesn't explain any of the thing. He just confuses on that hyper and hyponatremia term. It's very simple. Please read my notes first before going into the book. Okay. Yeah, treatment of nephrogenic DI. I just reading this thing in Harrison in the morning. You know, see, potassium and bicarb, learn more about this in adrenal problems, will change when the sodium value will change. A sodium potassium ATPase channel that is seen on the cells, if that changes the potassium and bicarb level. The reason of having hyponatremia in the patient is dilution. Dilution doesn't change the potassium level. It may change the sodium level, and if the potassium level changes, there is also a change in the bicarb level, acidosis, alkalosis. So that's one reason we could not see change of potassium and bicarb. Regarding the treatment, just a idea about this, diabetes insipidus, you can read in pharma book, given better than in pharma book, I've seen that. If the patient is having central DI, deficiency of DI, then in that case vasopressin is given. And it is actually a desmopressin nasal spray. It's not an injection, it is not a tablet, it's a nasal spray, very simple to be taken, desmopressin nasal spray. Patient snuffs it in, goes into the circulation 3 minutes, starts acting within 15 minutes. Easy to deliver, desmopressin nasal spray, central DI. As far as nephrogenic DI, there is a lot of confusion on this. What to give? See, you cannot give ADH. Why? ADH resistance. So ADH is not the drug of choice. Desmopressin nasal spray has no value. Now the problem is that the patient of DI is losing a large amount of water, is also losing a large amount of water in the urine from the body. So you can regulate that thing of urine output by giving a thiazide diuretic. A thiazide diuretic indirectly cause more of sodium reabsorption that will now put the water back into my body. So at least that polyuria kind of a story can be inhibited by using a thiazide diuretic. So they mention in the book that you can use a thiazide diuretic that can possibly help the patient out. But that's not the drug of choice anytime. This is just a supportive kind of a treatment. Okay. Any ideas about this? Break? Require a break? We'll take or 10 minutes break, because if I continue with the adrenal, nothing will go into your head. Okay? We'll take a short 10 minutes break, then we'll start the show again. Okay? If a disease at all occur in us, it occurs because of a normal physiological problem. If I remember from physiology, there is a pituitary gland that regulates the adrenal cortex to produce cortisol. How? Because anterior pituitary produces a hormone that is known as ACTH, adrenocorticotropic hormone, ACTH, that stimulates the adrenal cortex to produce a cortisol. A rise in cortisol, there is a fall in ACTH. This kind of a story in normal physiology is known as negative feedback. A fall in cortisol means a rise in ACTH. This kind of story is a positive feedback. So we got a normal physiological thing, negative and a positive feedback to understand. Now something important and relevant clinically in a patient with Cushing's syndrome is that Cushing's syndrome comes into the picture because of this loss of negative feedback. The cortisol keeps on rising up, but the ACTH doesn't fall down. That I understand as the word as loss of negative feedback. We'll come out in discussion again when we discuss the diagnosis part of this disorder, why this is so very important. Now looking at the cause of Cushing's syndrome, if I look at the cause, etiology of Cushing's syndrome, diabetes will be done today. If I look at the etiology of Cushing's syndrome, possibly it can be a problem upstairs, maybe in the pituitary gland, which I know as the word as a pituitary adenoma. Number 2, it could be possibly a problem in the adrenal gland, which is known as adrenal adenoma or adrenal carcinoma. Adrenal adenoma is more common than carcinoma histologically, radiologically. That's a surgical question. Adrenal adenomas are more common than carcinoma. Number 3, possibly can be a source outside that could produce ACTH, ectopic ACTH production. Ectopic ACTH production can occur very possibly in a malignancy. One of them, the very famous of all, is small cell carcinoma of lung, SCC lung. Second would be a pancreatic carcinoma, and third would be a carcinoid of the thymus gland. So these are 3 malignancies that could produce ectopic ACTH, can cause Cushing's syndrome. Out of the 3, you can put a tick on that, small cell carcinoma of lung. So that's an old MCQ one-liner question, typical. Most common malignancy causing Cushing's syndrome is small cell carcinoma of lung. Now something to understand at this point is that God-given gift to only these 3 malignancy, not any 4th, not any 5th very often. Like you imagine that a breast carcinoma produce ectopic ACTH? No. A melanoma? No. A renal cell carcinoma? No. So it's a God-given gift to only these 3, not any 4th. Number 4, we understand that we give steroids for treatment of various itis in my body, we end up having Cushing syndrome. So that is known as iatrogenic. Most common cause of Cushing syndrome is iatrogenic. Okay. One more MCQ one-liner again. Most common endogenous cause of Cushing syndrome that is within the body is a pituitary adenoma. Most common endogenous cause that is within the body is a pituitary adenoma. Then one-liner question again. Most common cause of Cushing disease. See, Cushing disease is a Cushing syndrome due to a pituitary cause. So if someone asks me a question, a very simple one, most common cause of Cushing disease, I'll mark it as pituitary adenoma, because Harrison mentions like this: Cushing disease is a Cushing syndrome due to a pituitary cause. So most common cause of Cushing disease will be pituitary adenoma. Okay. So these are few one-liner question. Most common cause of Cushing syndrome, iatrogenic. Most common malignancy causing Cushing syndrome, small cell carcinoma of lung. And most common cause of Cushing disease, pituitary adenoma. And most common endogenous cause of Cushing syndrome that is within the body is again pituitary adenoma. Clinical features. If I look at the disorder, what can be the clinical feature? I recall from basic biochemistry, physiology and all that cortisol is a glucocorticoid. Glucocorticoid word is given to that for one intention, that it will form the glucose. We eat food, we get glucose, but we can have a glucose formation also from other sources, breakdown of protein, breakdown of fat. This kind of a drama that I mentioned is a word gluconeogenesis. So if there is cortisol excess, there is a possibility it will stimulate gluconeogenesis because it's a glucocorticoid. It will break down the protein, break down the fat. So in the patient we have a protein problem. Protein are very often seen where? Protein are very often seen on the muscle. It will break down the protein on the muscle. As a result, the patient will have proximal myopathy. Yes. Protein can also be seen on the subcutaneous tissue. So there is a tear of subcutaneous tissue. As a result, patient will have stretch marks, which are certain purplish stria seen on the body, stria, stretch marks, and can also have easy bruising. Like I hit something, it only turns red on my arm, forearm. It never turns blue and don't develop an hematoma so very often, because subcutaneous tissue is made up of protein that is intact and protecting the capillaries underneath. If that subcutaneous tissue is not very perfect, it will break down the capillaries on a trivial trauma, easy bruising. Number 2, the most characteristic finding that we see in the patient is relation to the fat. Most of the time these patients have got weight gain, yes, and the distribution of fat changes from the very abdomen and thorax, where I have the maximal amount of fat. It shifts itself into the center of the body. Somewhere it is known in the book as a centripetal obesity. Okay, fine. Now centripetal obesity is a term that we use in relation to Cushing syndrome, distribution of fat in the center of the body. That gives a hump appearance on the back of the patient in the suprascapular neck region. This part is known as a buffalo hump. The deposition of fat on the face with some fluid can also result in a face which is known as moon-like face. Chand sa chehra, not beautiful like a moon, only round like a moon, moon-like face. Number 3, it is a glucocorticoid. It will unnecessarily raise the blood sugar, giving a high blood sugar value, which is known as diabetes mellitus. They write in the textbook that the high doses of cortisol can behave as aldosterone. Rise of aldosterone means rise of sodium. A rise of sodium means rise of blood pressure, hypertension. Now a rise of sodium means a fall of potassium with alkalosis, hypokalemic alkalosis. This thing is something very relevant now. Hypokalemic alkalosis as a phenomena is seen in one group of patients very often, patients who are having ectopic ACTH. So that was in a clinical setting that every patient of Cushing syndrome was looked into that. And they found that this phenomena, hypokalemic alkalosis, is very well and often seen in one group of patients, ectopic ACTH production. Okay, not in patients with pituitary adenoma, not in patients with adrenal adenoma, not in patients with iatrogenic cause. Okay. Number 5. In a female population, they found that it can result in hirsutism, excessive hair growth. It can become an androgen kind of a substance, again in a high dose, can result in hirsutism. And it also exerts an effect on the menstrual cycle in a female. Very often, it results in oligomenorrhea followed by amenorrhea. In this very particular sequence that is mentioned in most of the gynae and the medicine textbook. Now this sequence is so very important to differ out one disorder from this, hypothyroidism. Just a clinical presentation, a female who comes to my OPD with hypertension and weight gain, the first thing that it strikes me is hypothyroidism. For one reason, hypothyroid disorders are very common nowadays. Okay, but in hypothyroidism, what menstrual abnormality do you see the maximal? Tell me. In hypothyroidism, which menstrual abnormality do you appreciate most commonly? What menstrual abnormality occurs in hypothyroidism in a female population? Menorrhagia, not polymenorrhea, the word is menorrhagia. Okay, just to differ out from the hypothyroid disorder, these patients have got oligomenorrhea followed by amenorrhea. Number 6. They found that patients of Cushing syndrome, high cortisol in initial phases can become a CNS stimulant. As a result, the patient will eat more, will have more appetite, and possibly will sleep less. I believe I eat more, I sleep more. Even without eating, I sleep all the time. Yes. I believe this patient will have a sense of well-being. More well-being is euphoria. And if euphoria is too bad, he may turn mad, psychosis. So, in the initial phases, this results in a CNS stimulation. In later stages, it may result in CNS depression also. So patient in initial phases may have euphoria and psychosis, but later stages they find depression in the patient very often. Okay. Now I realized why iatrogenic is the most common cause. One reason, abuse potential. A patient went to a doctor, a quack. Doctor sahib, I am feeling very weak today. Give me some medicine. Doctor did not give him multivitamin. Give him a shot of steroid. Giving a shot of steroid will induce a sense of well-being. Patient feels better. Revisits the same doctor next day. Next day again he gets the same steroid. After 1 month, he looks like that typical centripetal obesity patient, Cushing syndrome. Why iatrogenic has become the most common cause? For one reason, cortisol, glucocorticoids are very often having an abuse potential like this one. Now I realized something from my old post-graduation days. I remember whole night duty, I was awake, everyone was sleeping, I was taking care of the patient. 9 a.m. I got the relief, 10 a.m. I went and had the breakfast, I went off to sleep, I did not sleep. 1:30 p.m. lunchtime, I had a good lunch, now I'll go to sleep. No, I could not sleep. Somewhere at 6 p.m. when the whole day has gone by, I thought I'll drink a cup of coffee, go to library, start reading. As soon as I went to library, I opened the book, I started sleeping. The reason is not psychological, the book, it is physiological. We realize this point in general physiology, that serum cortisol, somewhere, if I look at the variation, starts coming out in the body at a time 6:30 a.m. It gets its peak at 8:30 a.m. time, morning. Somewhere at 6:30 p.m. again, it starts dipping. And somewhere at 12 midnight, it is totally out of my body. So we see that normally serum sample of cortisol in the AM is more, while in the PM is less. So this is what is known as diurnal variation. So normally if I understand a serum cortisol, AM is always more than the PM sample. But in the patient who is having a Cushing syndrome or maybe a Cushing disease, the first thing becomes this, AM becomes equal to PM, which I remember in the word better in English, Loss of diurnal variation. So loss of diurnal variation means fall in the difference between the PM and the AM sample. PM becomes equal to AM. Both rise. Yes. So this is considered as one of the first sign of the disease. If I look biochemically a sign, this is something we'll let you know. Now a good doctor is a doctor who sees a patient of Cushing's syndrome, does a serum cortisol. But an intelligent doctor does a serum cortisol AM and PM. PM becomes equal to AM, one of the first sign of the disease. Okay. Now it's a normal physiology again. All hormones disappear after midnight. Okay. After midnight, one who is tall and strong will come out. Who? Growth hormone. Growth hormone is the only one that comes out after midnight. Rest, most of the hormones disappear. Okay. Now one-liner question again at this point. Most common manifestation, or rather presentation of patients with Cushing's syndrome symptomatically is weight gain. Weight gain happens to be the most common presentation of patients with Cushing's syndrome. Harrison has given an interesting table which he keeps the weight gain different from the central obesity. Weight gain happens to be more common than central obesity. Central obesity will come later. Initially they have weight gain. So there was a question again in National Board pattern that in patients with Cushing's syndrome, which of the following is the earliest symptom that they present with? Again, weight gain. Weight gain is most common and often the earliest symptom that the patient presents with. But the earliest sign is loss of diurnal variation. Now, what is happening, Cushing's syndrome is cortisol excess. I'll understand the drama again. I have more cortisol, yes, and I have got a stimulation for that ACTH. Now what happened? Cortisol went up normally, but the ACTH went down. This is also known as negative feedback. I did not have this kind of a thing, negative feedback, so that the cortisol went up to such a value it resulted in Cushing's syndrome. What was the cause? The cause was in the pituitary gland, pituitary adenoma. The cause was in the adrenal gland, adrenal adenoma. The cause was somewhere outside, ectopic ACTH. Simple. Now the thing is that a patient who comes to me with central obesity, patient who comes with a moon-like face, a female who comes with hirsutism, maybe oligomenorrhea, menorrhea, I cannot just look at this symptom and decide it is Cushing's syndrome. I need to prove it biochemically. I got a serum cortisol sample AM and PM done to help me for diagnosis. But better tool would be this. What do? Listen to me first. If I give you a tablet of steroid today to eat, maybe 1 milligram steroid tablet, dexamethasone, that revolves in my body whole night and tells me that this 1 milligram is extra for me. What is negative feedback? What you got, you keep it. What you can make, you stop it. So the exogenous steroid that you gave in a tablet form can inhibit the endogenous production of cortisol. Negative feedback. But in Cushing's syndrome, unfortunately, there is loss of negative feedback. So whatever steroid that went into your body went high and high next day morning. So I give you a steroid tablet to eat today and check your serum cortisol sample next day morning. It is obviously normal. Never abnormal. Why? Negative feedback. In Cushing's syndrome, there is loss of negative feedback, then becomes a trouble. So for diagnosing the problem, what do? The very first test is give a tablet of 1 milligram dexamethasone. It's a tablet, it's given oral. And next day morning I check the serum cortisol. If the serum cortisol is normal in the patient, it is not a case of Cushing's syndrome, minus. If the serum cortisol is high in the patient, it is a case of Cushing's syndrome, plus. Loss of negative feedback. Now the problem with me is that my patient in Cushing's syndrome might be having euphoria. He might be taking not 1 milligram, he may be taking 10 milligram. He is in depression, he may take 0 milligram. Becomes a problem. I am not sitting with him at the home to see how much tablet he is taking. What do? To make it more perfect in the diagnosis, I give milligram 0.5 milligram dexa again, but this time I give it under my observation from my side, IV, intravenously, 4 times in a day, 6 hourly for 2 days. If I calculate it mathematically, 0.5 milligram 4 times in a day will become 2 milligram. 2 milligram for 2 days will become total 4 milligram. This 4 milligram of steroid that went as an injection intravenously will inhibit the endogenous cortisol production in a person who is having a normal negative feedback. But in a patient who is not having a normal negative feedback, what will happen? Cortisol will go from 4 to 8, 4 to 12. So that's the story now. If on giving 0.5 milligram Dexa IV 6 hourly for 2 days, I go ahead and do a serum cortisol on day 3, I find the serum cortisol normal. That means the patient is not a case of Cushing syndrome. Negative feedback is perfect. But if the serum cortisol is again high, it means it is a case of Cushing syndrome plus. Fine. Now if I diagnose it as a perfect case of Cushing syndrome, what do? I localize the lesion. If I want to see pituitary adenoma, look into the diagram again. If I want to see a pituitary adenoma, I will get an MRI head done. If I want to see an adrenal adenoma, I'll get an MRI abdomen done. If I want to see an ectopic ACTH, God only knows what to get done. Becomes a big trouble. So what do we understand, This time, to localize the level of lesion, I give patient 2 milligram of Dexa IV 6 hourly for maybe 2 days duration. 2 milligram 6 hourly 4 times becomes 8 milligram. 8 milligram for 2 days, total 16 milligram. They found in experimental studies, if you give a high dose of steroid, cortisol suppression will occur. That means the negative feedback will start in a cause who is actually in a physiological axis. Tell me, if I look at the 3 disorders, pituitary adenoma, adrenal adenoma and ectopic ACTH, tell me, out of these 3 causes, who is in our physiological axis? Pituitary adenoma or adrenal adenoma or ectopic ACTH? Tell me. Who is in a physiological axis? Only a pituitary adenoma, not your adrenal adenoma. Adrenal adenoma is just a factory of the cortisol that has opened up inside the adrenal gland. Ectopic ACTH is someone from outside threatening the adrenal gland, while who is in the physiological axis is a pituitary adenoma. So they found that, if you give a very high dose of steroid to a patient and the cortisol goes down, that means the negative feedback starts operating at a very high level of steroid, then the case is a case of pituitary adenoma. If it doesn't change, it means it's an adrenal adenoma or ectopic ACTH. So what do I do further? I give patient 2 milligram Dexa IV 6 hourly for 2 days duration, and after 2 days I check upon the serum cortisol of the patient. If the serum cortisol starts coming down, possibly is a case of pituitary adenoma. If the serum cortisol is U, that is unchanged, then possibly it's a case of ectopic ACTH or maybe a case of adrenal adenoma. To differ out the two, high ACTH value will have a relevance. The patients with ectopic ACTH have got a high ACTH value. Just to name the tests that I have done till now, 2 milligram Dexa IV 6 hourly for 2 days is a very high dose of steroid. So the name that is given to it is high dose Dexa test. High dose Dexa test. That is done to delineate the level of lesion. Okay. This season we got an atypical question like this on a computer, that a positive response on a high dose Dexa test is suggestive of what? Pituitary adenoma. Positive means something good for the patient. Cortisol that was high started coming down, pituitary adenoma. Cause. Before it, the test that we did was comparatively a low dose of steroid known as low dose Dexa test. So there are 2 tests that we follow, high dose Dexa and low dose Dexa. See, plus and minus for one good reason. Low dose Dexa test is happen to be seen as a confirmatory test. So confirmatory test for Cushing syndrome is a low dose Dexa test, while high dose Dexa test is to tell me where is the lesion. And this was a question this season. The positive response on high dose Dexa test is suggestive of what? Something good, cortisol high coming down, pituitary adenoma. Treatment. Best will be to treat the cause, but there are certain drugs available with me which will inhibit the steroid synthesis. One of them, metapyron, and the second one, ketoconazole. So there are two drugs, metapyron and ketoconazole, that could inhibit the steroid synthesis at various enzymatic level that could really help the patient out. So this is a pharma question. Name two drugs which can be used for the treatment of Cushing syndrome, ketoconazole and metapyron. Write few questions on this. About Cushing syndrome, true is. About Cushing syndrome, true is. Low dose DEXA suppresses cortisone secretion. Low dose DEXA suppresses the cortisone secretion. Option A. Option B. Carcinoma of the adrenal gland is more common than adenoma. Option C. Pituitary adenoma more than 2 centimeter usually. Option D. Increased ACTH secretion is commonest cause. Which of the following is true about Cushing syndrome? Low dose DEXA suppresses cortisone secretion. Carcinoma of the adrenal more common than adenoma. Pituitary adenoma more than 2 cm usually. Raised ACTH is the commonest cause. Rhythm correct. Low dose DEXA suppresses the cortisone secretion in a normal subject, not in a patient with Cushing. Carcinoma of the adrenal, no. Adenoma are more common than carcinoma. This is something that I read in every guide. Pituitary adenoma more than 2 cm usually. He wants to tell me that macroadenoma are more common than microadenoma usually. No, it is always micro more common than macro. Increased ACTH secretion is the commonest cause. I'll go with this as the best answer. Although not the correct but the most appropriate. Because most common endogenous cause of Cushing syndrome, pituitary adenoma, that causes the Cushing syndrome by a high ACTH. Okay, I'll go with D as the best answer. Write one more interesting question. A 50-year-old male, chronic smoker, presents with hemoptysis. He is having truncal obesity with hypertension. Fine. He's got an elevated ACTH which is not suppressible with high dose DEXA test. Diagnosis. Option A. Bilateral adrenal hyperplasia. Option B. Adrenal adenoma. Option C. Pituitary adenoma. Option D. Ectopic ACTH producing lung cancer. A 50-year-old male with hemoptysis, truncal obesity and hypertension has got an elevated ACTH that is not suppressible with high dose DEXA. What is your diagnosis? Rhythm correct, ectopic ACTH. If a high dose DEXA test doesn't suppress the cortisol production, two reasons, adrenal adenoma or maybe ectopic ACTH, But better answer ectopic ACTH. Why? High ACTH, number one. And if you look at the history, chronic smoker and hemoptysis, most likely he is having a side effect of smoking, a lung cancer. Right, one more controversial question, which I regard as the word controversial. Right, this one. Differentiating feature between ectopic ACTH and Cushing syndrome. Option A, hypokalemic alkalosis. Option B, clinical features of Cushing syndrome. Option C, hyperpigmentation. Option D, hypertension. Differentiating feature between ectopic ACTH and Cushing syndrome. Any other answer? It's 75-25. I'm very sure if you read one of the guide, the answer is hyperpigmentation. If you read another guide, the answer is hypokalemic alkalosis. And another guide gives the answer as clinical features of Cushing syndrome. You know, even option D is one of the guide that has given the answer. The most toughest question I could ever read. You know, this is an old question 10 years back, and when I was appearing for the PG entrance, in that time they had asked this one. You know, we could not get a good answer on this till now, but it's a AIMS question. You don't have to mark the correct, but the most appropriate one. Funda is that. One guide gives the answer as hyperpigmentation. For one reason, they give a reference from the chapter of lung cancer in Harrison that hyperpigmentation often occurs in patients with lung cancer. Okay, ectopic ACTH will have hyperpigmentation. But tell me, will a patient of pituitary adenoma also have hyperpigmentation? Yes. Why? Because a pituitary adenoma wala patient also has got a high ACTH. But the ACTH value is not that high as an ectopic ACTH. So the hyperpigmentation is slow and gradual, but is seen in patients with pituitary adenoma. So just read this question like, what is a differentiating feature between ectopic ACTH and a pituitary adenoma? Hyperpigmentation, although late and gradual in a pituitary adenoma, more pronounced and severe in ectopic ACTH, but the hyperpigmentation will occur in both of them. If I see a patient with hyperpigmentation, I cannot just claim that this is ectopic ACTH. I need to look into the brain, pituitary adenoma also. As far as hypertension, one guide gives the answer as hypertension. He tells you in patients with ectopic ACTH, there is more ACTH, there is more cortisol, there is more hypertension. In pituitary adenoma, also hypertension can occur because that is also a problem via ACTH, although late and less severe as compared to ectopic ACTH. One guide gives the clinical features of Cushing syndrome. You know, in ectopic ACTH, if Cushing syndrome has to occur, it occurs within 4 days. While in patients with pituitary adenoma, it occurs over 4 months. So the time gap of clinical features is less and more short and more severe in ectopic ACTH as compared to pituitary adenoma. But clinical features of Cushing syndrome is the option, not the early and late, not like less and more severe. Best answer I could read in Harrison given is this, hypokalemic alkalosis. You know, there's a line in Harrison, not in the chapter of Cushing syndrome. You can go back and read Harrison again. When they're discussing prolactin and growth hormone, anterior pituitary, they discuss Cushing syndrome in just 2 pages. And he gives a line there that 90% of patients with hypokalemic alkalosis were patients of ectopic ACTH, while only 10% were pituitary adenoma patients. So what is more powerful to tell me ectopic ACTH versus pituitary adenoma? Hypokalemic alkalosis. More powerful technique, because hypertension, hyperpigmentation and clinical features occur in both of them. But hypokalemic alkalosis will become the most reliable marker to differentiate something ectopic ACTH versus pituitary adenoma. Okay. So I believe A will become the best possible answer. Although I claim this is again a controversial question, the answer in every guide will differ. But best answer, I see it as A. Right, one more controversial question. A 20-year-old female has put on weight 10 kg over a period of 3 years, and she's got oligomenorrhea followed by amenorrhea for the last 8 months. Her blood pressure reading that they have given in the question is 160 by 100 millimeters of mercury. What would be the next appropriate test? If such a patient comes to me in the OPD, what should be the next appropriate test to advise for her? Serum electrolytes, plasma cortisol, plasma testosterone, and ultrasound of the pelvis, or would be as simple as getting a thyroid done, TSH, T3 and T4. A 28-year-old female has put on weight for the last 3 years and she's got oligomenorrhea, amenorrhea and a blood pressure of 160 by 100. What should I get done? Cortisol or thyroid? Only two options actually. For clinical purpose, only two options. I was waiting for D. Because one of the guide gives the answer as D. Everything in the guide is not 100% correct. Cross-check in your textbook again. Guide gives the answer as thyroid for one funny reason, that more common, what is more common, hypothyroid or Cushing? Hypothyroidism is more common. So please rule out thyroid disorder in this patient. See, the question is not the first to be done, the most appropriate and the best that could be done. Like if you look at the question framework, oligomenorrhea followed by amenorrhea, more in favor of Cushing syndrome, one thing. And pregnancy is not in the option. That's a good choice. Allahabad Center, very nice choice. Pregnancy is not in the option, so don't think it to be pregnant so very often. You get a UPT done first. That's obviously right. Okay. Like in a Hindi movie, they do know. They just check the pulse of the patient and tell her that you are pregnant. Pulsus gravidarum, that you can possibly see in the Hindi movies. Okay. So jokes apart, like in this patient, if I look at the question, she's having oligomenorrhea followed by amenorrhea. Okay. And she's more likely to have Cushing rather than a hypothyroid disorder. And if I look at the blood pressure reading, this is very important, 160 by 100. I'll teach you hypothyroidism today and learn that in patients with hypothyroidism, they got a mild diastolic hypertension. They don't have a systolic and a diastolic hypertension very often like this. Okay. So this trauma goes more in favor of plasma cortisol, less in favor of thyroid. So I'll put the answer as plasma cortisol as the best answer rather than thyroid, because thyroid disorders present with menorrhagia very often and they got a mild diastolic hypertension to tell about rather than a systolic and a diastolic both. Okay. So plasma cortisol will overvalue a thyroid sample analysis. Okay. Now we'll consider the discussion on another important friend and enemy of us, that is aldosterone. Problem: hyperaldosteronism. I'm very sure we eat a lot of things outside and we end up having diarrhea. And in a diarrhea episode, gastroenteritis episode, you don't drink water so very well. Neither do you take probiotic or antibiotic, but still you survive the whole episode. But a poor patient in our government hospital passes out a large amount of stool outside, comes into our casualty, totally collapse. What's the reason? Our defense mechanism in us is lacking in aldosterone. So rise of aldosterone is a defense mechanism, secondary, a solution. You know what happens? Whenever I face a gastroenteritis, a volume loss occurs in my body, hypovolemia. Hypovolemia will pull out someone from the GG apparatus in the kidney, that is a renin auntie. Renin auntie will pull out the aldosterone uncle. As I already mentioned in a description in SIEDH, aldosterone is a mineralocorticoid. It will reabsorb the sodium, that will also bring along with it water. So there is reabsorption of sodium, more of water, and at the end of the day, the volume again falls to normal. So this is a solution. I have a hypovolemic episode. I don't develop hypovolemia because something protects me is aldosterone. Now the problem. Primary. There is a rise of aldosterone, there is a rise of sodium, there is a rise of water, there is a rise of volume. A rise of volume brings down the renin. Then a compensatory phenomenon occurs that I'll let you know later. Volume again shifts to normal. So what do I see in the whole drama? That if the renin auntie and aldosterone uncle are together, it's a solution. If renin auntie and aldosterone uncle are opposite to one another, it's a problem. So one is a problem, that is primary, other one is a solution, that is a secondary. Now the issue is that why will a primary hyperaldosteronism at all occur? Etiology. Number one cause, bilateral idiopathic cortical hyperplasia. Hyperplasia, I understand, is a gland that is just working hard on the cortex on both the side, bilateral, without any good reason. Idiopathic. Doctor is idiot, patient is pathetic. Idiopathic, unknown cause. Number two, possibly it can be an adrenal adenoma also. Now 1 and 2 for one good reason. If someone asks me the most common cause of primary hyperaldosteronism, I'll mark it as adrenal hyperplasia. But if someone asks me the most common cause of Conn's syndrome is adrenal adenoma, just a line from Harrison will help you out. Harrison mentions that the most common cause of Conn's syndrome is adrenal malignancy. He just gives you a line on that. So we learned that most common cause of Conn's syndrome is not adrenal hyperplasia, it's adrenal adenoma. Okay? So, but the most common cause of primary is hyperplasia. But the blunder which the guide Wallace does for us, he writes primary oblique Conn's and confuses the whole chapter from the very beginning. It's not primary oblique Conn's. Conn's is a type of primary due to adrenal adenoma, while primary most common cause is hyperplasia. Now the interesting thing is that aldosterone, sodium, water, volume high but volume normal. Why? Because the patient doesn't develop hypovolemia, he escapes out the whole drama. This kind of a story is very well known as an escape phenomena. Escape phenomena. How? There is a rise of aldosterone, it causes the sodium reabsorption. There is a rise of the sodium, yes. There is a rise of the sodium and there is also a rise of water. The sodium and water both come together, they rise the blood pressure. Due to some known unknown reason, they find that the diastolic BP often rises. As a result, in the patient, there is a rise of urine output, polyuria. And later stages, what happens? If you gain water, you lose water. At the end of the day, you don't have water, no edema. That's why the name was very interesting, escape phenomena. You gain water, you lost water, you escape out the edema, no edema, escape phenomena. Return gift. If the sodium rises, the potassium will come down, alkalosis, hypokalemic alkalosis. Uncle auntie, rise of aldosterone, fall in renin, hyporeninемia. So that's a very interesting story of a patient with primary hyperaldosteronism. They present with hyperaldosteronism, hyperenemia, hyponatremia with hypokalemic alkalosis, no edema, and polyuria maybe with hypertension. Treatment of such a patient, if it is hyperplasia possibly, could be a drug, aldosterone antagonist, that will block the aldosterone receptor. Okay, a good friend of mine for a long 50 years is spironolactone, which is an aldosterone antagonist, spironolactone. If I remember, spironolactone is a diuretic actually, and the word which we use for this is potassium sparing diuretic. Already my patient is having hypokalemia, so it doesn't touch the potassium value. Spironolactone. Write down this question. Only one question at this point, is easy one. Primary hyperaldosteronism can be diagnosed by following criteria except we'll start with option A. Diastolic hypertension without edema. Option B, hyperaldosteronism. Option C, hyporeninemia, low renin. And option D, metabolic acidosis. So which of the following is not seen in a primary hyperaldosteronism? Tell me. Answer is very easy. Metabolic acidosis. We see hypokalemic alkalosis in the patient. Simple one. Now we'll move into the opposite direction. We'll move in the opposite direction, in which we see a disease in which the adrenal gland stops working, known as Addison disease. Also named in the book as Addisonian crisis. Acute problem crisis, a long-standing disease. Adrenal gland stops working. There is deficiency of cortisol that the patient typically faces. Okay. Now, what can be a cause of this problem? Etiology. Fine. Number one, could be an autoimmune destruction of the gland. Number two, could be tuberculosis. Most common cause of Addison disease worldwide is autoimmune destruction of the gland. But in India, the national disease is always tuberculosis. Most common cause in India is tuberculosis. Okay, so there are two causes, autoimmune, most common cause worldwide, but in India it becomes tuberculosis. So the Addison disease patient faces a deficiency of cortisol in his body. Like there was more cortisol, the patient had Cushing syndrome. Patient had more sugar, more blood pressure, more sodium, more weight, more energy. I'll go into the opposite direction. Less of cortisol, what will happen? Patient will have low blood sugar, hypoglycemia, low blood pressure, hypertension, low serum sodium, hyponatremia. Return gift, more potassium with acidosis. Hyponatremic, hyperkalemic acidosis. And my patient, because of hyponatremia, will also have low extracellular fluid volume. Yes, that may result in hypertension again. Now the patient also has got one more trouble. Like, if someone has got hypoglycemia, body has a combating effect, counter-regulatory mechanism to make the glucose from breakdown of protein and lipid. Glucagon, cortisol, epinephrine and growth hormone are the three things that help me out for this phenomena. But in the patient there is no cortisol, no problem. But there is growth hormone, there is epinephrine, there is glucagon. They will make the glucose by breakdown of protein. As a result, the patient has got thin body habitus or weight loss. This possibly occurs due to increase in the protein breakdown. And in the patient, like Cushing syndrome was more euphoric, more energetic. This patient is having asthenia. That is, this patient is having fatigue and lethargy. So out of the all symptoms, that was a question one-liner this season, that most common electrolyte abnormality that you see in patients with Addison disease is hyponatremia. Okay. Now the thing is that the cortisol goes down and there is a reflex positive feedback that will rise the ACTH. So there is a reflex rise of ACTH. So the ACTH comes out from the pituitary gland. It knocks the door of the adrenal gland. Toc toc, give me cortisol. But the adrenal gland is closed due to autoimmune or tubercular process. What happens? ACTH doesn't go back and sit in the pituitary. It deposits on the skin, becomes an MSH. As a result, patient has got hyperpigmentation. That doesn't mean that someone has got Addison disease today, tomorrow he'll turn jet black. No, no, no. Now, not the whole body, a part and parcel, localized hyperpigmentation. That's a very specific thing that we see in this patient, localized hyperpigmentation. Now, if I want to diagnose this kind of a disease, Addison disease, what do? I give him ACTH. If I give an ACTH for a normal subject, what will happen? Cortisol will rise up, yes. But if I give ADs to a patient with Addison disease, what will happen? Cortisol level will be unchanged. Why? Because the adrenal gland is totally dead. It is dead due to autoimmune or tubercular process. So there is no change in the cortisol level on giving ACTH. So ACTH stimulation test will become one of the very good diagnostic tests for Addison disease patient. Treatment. Just a brief description on this. There is deficiency of cortisol, you give steroids. The steroid of choice is hydrocortisone. Please, it's not dexamethasone. I've read one of the guide recently, he mentions the answer is Dexa. No, Harrison and every endocrine book wherever I read it is always hydrocort. See, Dexa is long acting, hydrocort may be shorter acting, injectable steroid. But hydrocort as a potential benefit is more seen as compared to Dexa. So giving hydrocort will instantly relieve the patient, not compared to Dexa one. So drug of choice for acute adrenal crisis. If someone asks me that question, I'll not mark Dexa, I'll mark hydrocort. And something extra, if the patient in India, think of tuberculosis, ATT. Normally in clinical practice, you don't give ATT to steroids to a patient who is on tubercular treatment. It might flare up the TB process, but you give steroids to a patient who is tubercular. When? We gave it just now, adrenal TB, Addisonian crisis. Okay. One thing we gave last class, TBM, tubercular meningitis patient. And we also give nowadays to the patient who are having pericardial effusion. They learn that pericardial effusion will drive because of the effect of ATT. But once it drives, it leaves behind pericarditis. That can be a problem lifelong to the patient. So give steroid to prevent pericarditis. And the last and the latest one that we now nowadays know is miliary TB. Miliary mottling in the lung. You learn in respiratory physiology and medicine. Miliary mottling in the lung is more dangerous than a cavity actually. Miliary mottling in the lung will progress to ERDS due to proliferation of the tubercles there. To prevent that proliferative phase, you give steroids. So steroids and TB, 4 direct indications that I know. Okay, write down one question on this. Chronic adrenal insufficiency. Chronic adrenal insufficiency is characterized by all except option A, excess of pigmentation, option B, oh no, don't write excess pigmentation, write it as low blood pressure, hypertension, increase protein breakdown, decrease in the extracellular fluid, increase in the sodium potassium ratio. A patient with chronic adrenal insufficiency will have all except. I hope rhythm correct, because we see in patients with adrenal problem, Addisonian crisis or Addison disease, low sodium and a high potassium. If I look at the ratio would actually decrease, not increase. So this is something best. Low blood pressure, low ECF, all explanatory. Increased protein breakdown due to gluconeogenesis, thin body habitus, weight loss. But this thing is not possible. Rise of sodium potassium ratio. Okay. Now we'll take the story further and we'll see the problem somewhere up in the parathyroid gland. Again, a parathyroid hormone produced by the parathyroid gland, our friend and our enemy, PTH. I'll not go into a bigger detail like a surgeon would do, like an orthopedic surgeon would do, because the topics like parathyroid and thyroid are overlap between me and surgery sir, and the discussion more often and the questions that we are asked are more often from surgery rather than from medicine. So it will not be very extensive in our discussion here like we did till now. We have a lot of discussion on various topics, but here it's a very concise discussion. First, parathyroid hormone, our friend and our enemy. Okay, why a friend? You know, a body faces a calcium deficiency. What happens? The body has got a good ATM machine to draw the calcium out, a bone. Who resolves the bone by osteoclastic activity? PTH, to get in the calcium back which is already stored with me. There is also act on the intestine. In the food that I take the food, there is also calcium in the food, but most of the calcium come out in my fecal matter. Now I can increase the absorption of calcium in the food by PTH. And we also lose calcium in the urine. We can stop the urinary loss of calcium by reabsorption. So we understand that PTH is our friend or enemy for one sense. Normal physiology tells me that parathyroid hormone acts on the bone. It causes the resorption there. It also acts on the intestine and causes the absorption there. It often acts on the kidney and it causes the reabsorption there. So it's all English that we need to understand. The word is resorption, absorption and reabsorption. Parathyroid hormone has a capacity to act on the bone, intestine and the kidney. So that's the basic physiological principle that you need to know. PTH, our friend or enemy. Why? PTH rise, hyperparathyroidism, is something that you see as a solution. We recall the term as secondary solution. Why? In my body I have got a disorder in which I see low calcium level. How? One reason, a very common reason, chronic kidney disease, CKD. The word CRF is no more. The word is chronic kidney disease now, CKD. Another one, vitamin D deficiency, that also results in hypocalcemia. And the third is rare disorder, although malabsorption. So CKD, vitamin D deficiency and malabsorption are the three things in which we see hypocalcemia, and we see a solution, rise of PTH, drawing the calcium from the bone, from the intestine and from the kidney. Another one, problem, primary. I see the problem as primary, yes, but the thing is that why a problem will occur? It occurs because the parathyroid gland is working hard, which is known as parathyroid hyperplasia. It can also be seen as a problem when the parathyroid gland develops a malignancy, parathyroid adenoma. If I look at the location of the parathyroid gland, it is around the thyroid gland on the first floor in the basement. All four parathyroid glands don't enlarge in parathyroid adenoma, only one of them enlarges. So most common type of parathyroid adenoma that you see clinically, radiologically, is a solitary adenoma. And the most common site is not above, it's below, inferior parathyroid lobule. So these are two important surgery questions that are asked in surgery point of view. Most common cause of primary is parathyroid adenoma, most common type is solitary adenoma, and most common site is inferior parathyroid lobule. So one question again, most common cause of primary hyperparathyroidism is always a parathyroid adenoma. Now the thing is that which is not often discussed in surgery is tertiary. Tertiary basically means a goon that has become a don. Hyperplasia became an adenoma, that is known as tertiary hyperparathyroidism. So due to any reason there was hyperplasia, maybe a secondary, maybe a primary, but I left it untreated, undetected. Over a period of years it became an adenoma, that is tertiary. So we understand that rise of PTH is a solution, is a problem, is a bigger problem. Why? A solution secondary to drive the calcium level normal, a problem primary, and bigger trouble tertiary. Hyperplastic gland became an adenoma. Now the whole burden of calcium comes on that ATM machine, the bone. So in patients with secondary, primary or tertiary, whatever you want to tell about, they often have got certain bony changes. These bony changes are something highly suggestive of this hyperparathyroidism. One of them that you learn in orthopedics is loosening of the bone, known as osteoporosis. Due to loosening of the bone, they often develop fractures so easily, which is known as pathological fracture. And if I look at the X-ray or maybe look at the cut section of the bone, I see areas of gap inside it, which are cystic areas around which there is inflammation in the bone and around which there is healing. So everything under one roof is put into word as a Greek term, a very famous term, osteitis, fibrosa, cystica. So areas are cystic, cystica, around which there is inflammation, osteitis, and around it there is some healing, fibrosa. We understand if there is a more of osteoclastic activity that you see in the bone due to PTH. Because of osteoclastic activity, calcium will come out. I agree with that. But some blood vessels in the Harvestian canal will get damaged. As a result, the blood comes out. Blood comes out, sits in the bone. On clotting, the blood never looks red. It changes the color, becomes brown. So it looks like a tumor in the bone, which are known as brown tumors. The word is tumor, but it is pseudotumor, not an original one. It is just the accumulation of the blood pigments inside the bone as a growth brown tumors. And something that you will learn more often in your radiology classes. These patients, if I do an hand X-ray, they have got a subperiosteal resorption of phalanges. So if I do the hand X-ray, I see the subperiosteal resorption being seen on the bone of the hand. This is known as subperiosteal resorption of phalanges. Okay, so these are some excellent bony changes that you see in a patient with hyperparathyroidism. Now the whole problem and the whole drama comes onto one stage. Secondary is a solution, primary is a problem. Why? Primary is a problem for one metabolic problem that is known as hypercalcemia. See, in secondary, the calcium was low, became normal, solution, secondary. But without any low calcium, the calcium went up and up and up. That is hypercalcemia, a problem. What are the clinical features that you look into the patient suffering with hypercalcemia? One of them, patient is having nausea and vomiting. Other one, patient often has complaints of abdominal pain with constipation. And also due to osteoclastic activity which may be happening, the patient also experiences bony pain. With calcium deposition occurring in the renal tubule while coming out, they develop renal stone or renal caliculi. This calcium can affect the brain also, can result in depression, can affect and can cause psychosis. And something never to forget, it's an osmotic or solute diuretic, can result in polyuria. So somewhere in the famous surgery guide I read it as moan, groan, bony pain and renal stone. It's a renal caliculi, renal stone, bony pain, patient is shouting, patient is crying, psychosis, shouting due to abdominal pain. So the word that comes in favor of a hypercalcemic state is a very good saying, moan, groan, bony pain and renal stone. Now something to remember from medicine part, if you use a lot of water from your body in the urine, polyuria, there is lesser water in the body that causes dehydration. Once dehydration occurs, it decreases the renal blood flow to the kidney. As a result, the patient has got pre-renal ARF. AKI is a newer term, ARF is an old term, pre-renal is the word. You learn more often this thing in the nephrology classes. If there is dehydration, maybe volume loss due to dehydration due to gastroenteritis or maybe anything, it is pre-renal ARF causing a damage to the kidney. If the patient is having diabetes, hypertension, glomerulonephritis, that is causing damage of the kidney, that is renal. Sometimes in surgery, a stone sticks down to the UV calculus, UV junction, that causes back pressure changes, hydronephrosis, that damages the kidney, that is post-renal. So renal caliculi, post-renal, diabetes, hypertension, renal, and dehydration, pre-renal. Treatment. See, remember one way of learning this topic. D for death, D for dehydration. A patient of hypercalcemia doesn't die of psychosis, doesn't die of cardiac arrhythmia. He often dies of dehydration. Dehydration, prerenal ARF. Treatment. Treatment number one would be giving a good amount of IV fluids to the patient to just maintain good hydration so that the patient doesn't go into dehydration. Number two would be giving a diuretic. You might think, sir, D for death, D for diuretic again. That will increase the urine output, sir. It will kill the patient. No. Some diuretics are having a property or having a calciuric effect. They will increase the calcium excretion. One of them is thiazide and other one is loop. Tell me, which diuretic is preferred? Loop or thiazide? You can just write L or T. L, loop, or a thiazide diuretic. Good. Rhythm correct. Loop diuretics are used in hypercalcemia. Thiazide diuretics are used in hypocalcemia, not the thiazide. Okay. So whosoever is forgetting is a Gajini, he can make a tattoo of thiazide and scratch it off. Okay. So loop diuretic like furosemide, ethicronic acid are used for hypercalcemic state. They are having a calciuric effect. Number three. Number three are the modern day medicines that we remember, which are known as bisphosphonates. Bisphosphonates are some drugs which are launched around some 10 years back, and the mechanism of action is they are osteoclast inhibitor. They inhibit the bony resorption. They will at least not weaken out the bone. That is occurring in patients with hyperparathyroidism, pathological fracture. So they will decrease the calcium by inhibiting the osteoclastic activity. A good name, a good surname that they all have, that is dronate, zolidronate, pamidronate, and etidronate. Zolidronic acid, pamidronic acid, etidronic acid. These are the names that we have for this bisphosphonate group of drugs. Number four. One more thing just to add to our knowledge. This bisphosphonate don't start acting on the day you give it. They act somewhere after 24, even 48, even 72 hours. So we learned that from pharma and orthopedic section, they have a delayed onset of action. They don't start working on the moment you give it. They may have a delayed onset of action. Maybe after 3 days they have an effect. Okay. So as a moral of story, what I realize, if a patient comes to me with acute hypercalcemia, bisphosphonate will not immediately control the calcium level. They take a time, 3 days time for action. Number four, till the time bisphosphonates were not available to us, we were handling the whole situation with two drugs. One was plicamycin and the second one after that was gallium. Plicamycin and gallium are nothing but they are osteoclast inhibitor again. So these are the two drugs, older drugs, that we need to just know the name of them, plicamycin and gallium. They are osteoclast inhibitor. We in a clinical setting can give an ultra hormone of PTH, that is calcitonin, also to the patient. Number 7, we can remove the calcium by doing dialysis even. Okay. So this is lucky 7 for the patient. And number 1, hydration, IV fluids. Number 2, a diuretic, this is thiazide, this is loop, not thiazide, and a bisphosphonate for a long-term therapy. For an acute control, even dialysis and calcitonin can be taken up for the patient. Write down one interesting falsely, wrongly given guide answer this question. Write it down. 75-year-old lady with fracture NOF, neck of femur, NOF, neck of femur, presents with 2 days history of altered sensorium with oliguria, A female with a history of fractured neck femur comes with a history of 2 days of altered sensorium with oliguria. We checked upon her serum calcium level. It was in a range of 15.5 milligram per deciliter. If you realize something from your general knowledge, the serum calcium ranges between 8 to 11. 11.5 is still normal. 9 to 11, sorry. Still it is normal. But 15.5 is extremely high. Her blood urea that we noticed was 140 milligram per deciliter. Her serum creatinine that we have measured is 2 milligram per deciliter. Urea upper limit you can take it as 40, but 140 is very very high, and creatinine upper limit in the lab is 1, but in book is 1.5. 2 is slightly high. Something we learn from clinical practice: if the urea is very high and the creatinine is slightly high, the story is pre-renal. Okay. If the urea is less high and creatinine is very high, it is renal. So pre-renal ARF may be a story that the examiner wants to tell me through, because the patient has got hypercalcemia. That resulted in pre-renal ARF. That resulted in oliguria. Ideally, a hypercalcemic patient would be having polyuria, but this time she is having oliguria because of pre-renal ARF. Because of high calcium load, polyuria, dehydration, and then pre-renal ARF. So the whole story is hypercalcemia. If you correct the hypercalcemia, everything will be reversible. Now the question is that all of the following are useful for immediate management of hypercalcemia, except. Whenever you get the word except, be careful. Don't be in a hurry. Always read this word except carefully. If there is sometime except which is not used. Option A, normal saline. Option B, furosemide. Option C, dialysis. Option D, bisphosphonates. Give me a good answer on this. Normal saline. Rhythm correct bisphosphonate for one reason. Bisphosphonate don't immediately correct the calcium level. Okay. Second thing, with the pharma people told me that a bisphosphonate should not be used in a patient with a deranged kidney function test. They are often not used in a patient with renal failure. Maybe a prerenal, renal, postrenal, anyone. So bisphosphonate will become the best answer because they don't immediately control the calcium level. They take a time, 2 to 3 days to act, and immediately control bisphosphonate won't be a very good drug, and they're not used in a patient with deranged KFT, deranged renal profile. But my dear friend, I was waiting for someone to answer it as B, because one guide gives the answer as A, another guide gives the answer as B. Normal saline. One guide gives the answer as normal saline. He tells me if you give normal saline to a patient who is suffering with renal failure, patient might go into renal fluid overload. Oh my God. My patient is having pre-renal ARF. I need to give him normal saline the first till the last day of his life. That will at least prevent the dehydration phenomena and may be also helpful for correcting the calcium level. Okay. One guide gives the answer as furosemide. Interesting. And he gives us 6 to 7 pages explanation on this furosemide. If the guide gives you a wrong answer with a lengthy explanation, this is what is known as confabulation, false story. You will believe him. He gives you a funny explanation. If you give furosemide to a patient with renal failure, the renal derangement will worsen. Oh, I remember, I'll give you a clinical setting on this. If you see a patient in your casualty with severe dehydration, you first give him an IV fluid, 3 to 4 liters. He doesn't pass out urine. What do you do? What do you do? After putting in a Foley's, after giving 4 liters to a fluid to the patient, he doesn't pass out urine. You give him a shot of Lasix, furosemide. The doors of the kidney will open up and he'll start passing out urine. Giving furosemide doesn't worsen out the renal failure. This time the furosemide is not given to push out the urine, to correct the oliguria. It is to push out the calcium out of the body, calciuric effect. So furosemide immediately works. Yes, it is helpful. Dialysis, although in this setting is too far-fetched an answer, but dialysis will immediately correct the calcium level. So dialysis can be used. Bisphosphonate, the best ever answer. Okay. So everything that you read in the guide, please cross-check it from your textbook. It's not always correct. Now in a clinical setting, what we understand is that a patient with malignancy, learn in surgery very often that some malignancy have a potential of producing PTH, ectopic PTH production. Ectopic PTH production will mean more calcium, more PTH, more calcium. But the story figure is that I started a treatment for a malignancy with radio or chemotherapy. I started showing a fall of calcium. Instead of the rise of calcium that was supposed to get maintained because of ectopic PTH, I saw a fall of calcium. It's a very bad sign. We are going into a stage which we realize as tumor lysis syndrome. A very famous thing, but a very simple thing. A tumor cell ruptures. Tumor lysis is the word that tells me about it. If the cell ruptures, something comes out very often, nitrogen, uric acid. If hyperuricemia occurs, my patient will have renal failure. Bad. If the cell ruptures, especially the tumor cell, potassium comes out. Hyperkalemia. Hyperkalemia means acidosis. Hyperkalemic acidosis. Hyperkalemia, return gift, hyponatremia. So in the patient with tumor lysis syndrome, we get hyperkalemic acidosis with hyponatremia. And when the cell ruptures, phosphate often comes out and calcium dips down. So like sodium and potassium, like dopa and acetylcholine. Like dopa and acetylcholine in the very first class were anti and opposite, mother-in-law, daughter-in-law. Dopa rises, acetylcholine comes down, acetylcholine rises, dopa comes down. Then we shifted our frame to sodium, potassium. Sodium goes up, potassium comes down. Same is this, phosphate and calcium. Okay. Phosphate rises and the calcium comes down. Always a multiplication of phosphate into calcium is 0.8 in the body. This we learn in nephrology again. Phosphate rises and the calcium comes down. So in a patient who is having malignancy, I should have hypercalcemia, but I start seeing hypocalcemia. That is a very bad sign. Tumor lysis syndrome, for one reason very bad, because at the point when I am having hypercalcemia, I am having hyperkalemic acidosis with renal failure, something to instantly kill the patient. Now the thing is that sometimes in clinical practice, you remove the thyroid gland, you remove the parathyroid gland. Hypoparathyroidism. A patient post-thyroidectomy may have hypocalcemia due to hypoparathyroidism. But I had a patient in my ward who had hypocalcemia, yes, but that patient did not have hypoparathyroidism. Instead had more PTH level in the body. He looked like hypoparathyroidism, but it wasn't that. The word is pseudo-hypoparathyroidism. Like a hypoparathyroidism, the word is pseudo-hypoparathyroidism. Okay. Such patients have got low calcium, fine. But we had this patient with a high PTH. Normally high PTH, high calcium, this time high PTH and low calcium. Why? Because the PTH formation was normal, but the PTH action was not normal. On the bone, on the intestine and on the kidney, wherever it was supposed to act, resorption, absorption and reabsorption, it could not do it. There was a resistance to the PTH hormone, and we saw a disorder which is known as pseudo-hypoparathyroidism, like a hypo, pseudo-hypo. But the problem technically is that if I see a patient with low calcium and a high PTH, I think it is a solution, secondary solution. But it is not secondary hyperparathyroidism. Why? Because patients with pseudo-hypoparathyroidism have got this. A typical body habitus that is known as Albright hereditary osteodystrophy. All of them have got a similar body habitus which is known by the term Albright hereditary osteodystrophy or AHO phenotype. What does this mean? These patients usually have got a short stature, short height. With a short height they have got a round face, yes. With everything they have got a short and fourth and the fifth hand bone, that is known as metacarpal, which is known by the term brachydactyly. So they have got a short fourth and fifth metacarpal, the hand bone, that is known by the term brachydactyly. They got a round face, they got a short stature, that is known as Albright hereditary osteodystrophy, AHO phenotype. That is very well seen in patients with pseudo hypoparathyroidism. Okay. Now another confusing term that you read in your textbook is this, but a very simple one: pseudo hypoparathyroidism. Two pseudos in that. Looks like two Shris, Shri Ravi Shankar. Two Shris, two pseudos. Now the thing is that this patient did not have a serum calcium abnormality, did not have a PTH abnormality, but they only looked like a pseudo. They had an AHO phenotype. So these patients have got an AHO phenotype. They look like a pseudo, but they are not pseudo. The word is pseudo hypoparathyroidism. So they are the pseudo of the pseudo hypoparathyroidism. So these patients have got a normal calcium, normal PTH, only they look like a pseudo, but they are not pseudo. The word is pseudo hypoparathyroidism. Okay. So that's the only thing that you need to know about this topic, because the textbook, the guide often confuses you a lot on this. This is the minimum and the maximum thing. Pseudo and tumor lysis syndrome. Any doubts on this one? Oh, lunch break. Good. Arey Baba, secondary and pseudo, the main difference is this. You know what happens is, in secondary there is rise of PTH and fall in calcium, but in pseudo there is a resistance to PTH. That's one reason. And patients of pseudo and secondary hyperparathyroidism, pseudo wala will have a typical body habitus, Albright hereditary osteodystrophy. Alpha, this is the only confusion that the textbook creates. GS alpha mutation. So there are certain mutations that are seen in patients with pseudo and pseudo. There's something to remember about. Okay. This is the mutation problem. That is one etiology that they give in the book. They carry that gene same as that of pseudo. So it's basically a genetic problem in which, you know, the PTH resistance happens. So that is the only gene that they carry with that. Okay. Lunch break. Yes or no? Yes. Because you are fasting, you might be sleeping. So it might happen you might become a khali, start hitting me. Sir, we'll hit you today. Okay. So prophylactically we'll take a lunch break. Same, Aam Aadmi, half an hour break. Okay. Slide 1 and 2, Gulbarga Center. Which slide 1 and 2? Starting which? Prolactin or this session, adrenal? Okay. ये वाली slide. Okay, fine. Can I begin? Can I start? Shall we begin? Okay. Now we discuss another important topic. Diabetes mellitus. First, the basic physiology regarding diabetes and insulin. We all understand that we take the food. The food contains glucose. that easily goes into the intestine. In the intestine there are peptide structure which are formed, which are known as incretins. Incretin in turn stimulate the beta cell of pancreas to produce a molecule for glucose homeostasis, that is insulin. Now the work insulin does is to push the glucose molecule within the cell. So insulin basically performs the function of a glucose facilitator molecule. Okay. So we understand that insulin is good for us. Whenever I take in food, my glucose moves into the cell, normal, perfect. Now diabetes comes into the picture if the beta cell is unable to synthesize insulin, or there is a possibility that the insulin cannot act on the peripheral tissue. That is, we face a problem of insulin deficiency or possibly insulin resistance. So what will happen? Whatever food I take in, whatever glucose I take in, it revolves around the cell, it doesn't go into the cell. I take in food, my sugar level is normal. If I take in food and my sugar level is high, that is a case of diabetes insipidus due to deficiency or resistance to insulin. Now we consider that diabetes is put into two types: insulin dependent diabetes and non-insulin dependent diabetes. Not long back, around 10 years back, when I started studying this topic, I was told that the insulin requirement from very beginning to the end of the disease is insulin dependent diabetes. Our OHA requirement is non-insulin dependent diabetes. But the thing is obsolete now for one reason. We saw over a 10 years gap, a patient who was on OHA went on to take insulin. So NIDDM became IDDM. So the best nomenclature to define or classify diabetes is in two headings. That is type 1 diabetes and type 2 diabetes. So there are two kinds of diabetes that we see, type 1 and type 2 diabetes. In type 1 diabetes we see a deficiency of insulin because the beta cells are not working, while in type 2 diabetes the insulin is not able to work on the cell, insulin resistance. That is type 2 diabetes. So if you want to classify diabetes, we classify it very broadly into two types: type 1 and type 2 diabetes. A clinical difference between the two: type 1 diabetes, beta cells are actually destroyed. They write in the book that around 90% of the beta cells are destroyed in a patient who is having type 1 diabetes, and in that patient the insulin is not formed in the body. The patient faces a problem of insulinemia. Okay. Type 2 diabetes, the patient basically has got insulin resistance. And the second defect that we need to consider is a secretory defect in insulin. The insulin is formed in the beta cell but it is unable to come out. If you remember from pharmacology that sulfonylureas, a secretagogue group of drugs, they are pushing out the insulin from the beta cell. So if the patient is having a secretory defect, they have a benefit by using sulfonylurea, a group of drug. But to explain type 2 diabetes, more appropriate theory is insulin resistance. I'll put a tick on that. Insulin resistance is more appropriate theory. Now type 1 and type 2 diabetes again. Type 1 diabetes, type 2 diabetes, the insulin resistance is the main cause, and these patients have got hyperinsulinemia. So the insulin level in the body is high, they suffer with hyperinsulinemia. And in type 1 diabetes we understand in type 1 diabetes the problem is more often HLA mediated. So that was an old question, that which of the diabetes is HLA mediated. It's type 1. See, the beta cell destroyed is all because of some immune reaction in the body. Some unknown antigen comes, develops an antibody, and it cross reacts with the beta cell. So it is more likely a human leukocyte antigen mediated kind of a damage, HLA. While type 2 diabetes, in type 2 diabetes patient, family history is often significantly positive. A very strong family history is seen in patients with type 2 diabetes. Type 1 diabetes, as the onset is seen often at an age less than 40 years, and type 2 diabetes, the onset is often seen beyond an age of 40 years. Type 1 diabetes patients are often thin, while type 2 patients are often obese. Type 1 patients suffer with a peculiar problem of hyperglycemia that we know as diabetic ketoacidosis, DKA. We'll discuss this topic in detail. While type 2 patients often have got associated hypertension and dyslipidemia. And type 2 patients are often got this problem, which is known as hyperosmolar coma. Hyperosmolar coma. Okay. So we'll discuss that topic also in greater detail. So we got type 1 and type 2 diabetes, two kinds of diabetes. Now that day in the OPD I saw a patient. I'll tell you my experience about this. I saw a patient who was actually a diabetic for the last 10 years and his age was just 35 years. He was a type 1 possibly, young age. He was also thin, young age, type 1 diabetes. But something written wrong on his prescription was OHA. He was on tablet and he was happy on tablets. He was not taking insulin. I immediately alerted him that to please take insulin, that will be better for you. He said, no, I'm very happy on OHAs. I said, you may be unhappy one day, you may develop ketosis. He said, no, don't worry. For the last 10 years, I never had ketosis. Then I again said, no, you are thin, lean, you are young, you are type 1, shift to insulin. He said, no, doctor, wait a minute. Same kind of diabetes is seen in my father and my grandfather. I said, it's a family history, type 2. No, that is autosomal dominant inheritance. 2 successive generations are affected. So we have a disease which doesn't fit into type 1, which doesn't fit into type 2. That is known as maturity onset diabetes in a young. Well abbreviated as MODY. Maturity onset diabetes in young. This kind of diabetes has been seen to start at an age 10 up till an age of 25 years. This kind of diabetes responsive patient. So patient who is OHA responsive, young and thin, doesn't fall into type 2, type 1, doesn't fall into type 2, falls in intermediate type, which is known as maturity onset diabetes in young. Another important factor, these patients don't have hypertension, neither do they have diabetic ketoacidosis or DK. So in these patients you don't see hypertension, you don't see DK, they are young thin individual who are OHA responsive and they don't fall into type 1 and type 2, which is known as MODY. As a matter of fact, there are around 6 types of MODY. Out of them, the type 3 is most common. You know why this MODY problem occurs into the clinical practice? Because the insulin was trying to shift the glucose into the cell. But the amount of insulin that was supposed to come out with that amount of glucose load wasn't that proper enough. So OHA responsive patients don't have this kind of a thing. They don't have that much insulin in the body that could respond to that much glucose load. And there was a glucose being taken into the cell and metabolized by various enzymatic pathway, glycolysis and Krebs cycle. Now what happened was, there was an enzyme HNF1 alpha. A problem at that enzyme caused this problem, type 3 MODY. So this was a question in AIIMS around a year back, that we found that MODY most commonly occurs due to deficiency of what problem? HNF1 alpha, hepatocyte nuclear factor 1 alpha. So most common type of MODY out of 6 type is type 3, and that very well happens due to HNF1 alpha deficiency. Okay. Now how do we diagnose diabetes? Diagnosis of diabetes. The diagnosis of diabetes is often done on the symptomatology. Signs and symptoms of diabetes. One of them is polyuria, other one is polyphagia, and the third one is polydipsia. Polyuria, polyphagia and polydipsia, these are the 3 clinical triads that define a patient with diabetes. With another important thing that we need to consider is weight loss. Why? A patient who was obese, a type 2 patient, initially started losing weight in spite of a very good appetite. He is having a disease diabetes. Why? Because the glucose cannot perfectly shift into the cell. Okay, the cell has to make the glucose now. The cell makes the glucose by breakdown of protein and lipid. So that is what is known as gluconeogenesis. In that attempt, the cell shrinks, the body loses fat and protein, and the patient typically has got weight loss. Plus a non-healing wound. Sugar rises, infection rises, sugar rises. It's a vicious cycle. So non-healing wound is again a very important signal to suggest me it's a diabetic patient. With everything said and done, the random sugar of the patient is more than 200 milligram per deciliter. That's a case of diabetes. Okay. Or a fasting blood sugar which is more than equal to 126 milligram per deciliter. That's again a diabetic patient. Or fasting. How many hours of fasting? Tell me. How many hours of fasting? Option A, 4 hours, 6, 8 or 12. No, my dear friend, fasting doesn't mean an overnight fasting. Overnight fasting is for a layman term. For a medical term, it is no calorie intake for 8 hours. So no calorie intake for 8 hours is defined by chemically as fasting. You use the word overnight just for the patient's sake, but for the clinical aspect you should consider minimum 8 hours. Minimum can go to 12 hours, but minimum 8 hours is a definition for fasting. Or oral glucose tolerance test, a very important test that you can perform in the patient. What do? You give patient 75 gram of glucose. After 2 hours you check the blood sugar of the patient. If it is exceeding 200 milligram per deciliter, that's definitely a case of diabetes. The word is always oral GTT, glucose tolerance test. Like I take glucose, it produces incretins, incretins stimulate insulin, insulin will shift every glucose molecule into the cell. If there is a problem in production, secretion or action of insulin, that amount of glucose will remain in the blood and the sugar level will go beyond 200. That's why the tolerance test, you do not tolerate that amount of glucose which is given orally. The oral GTT is the word. And latest update that came in ADA criteria for diagnosis of diabetes would be to get an HbA1c. We'll discuss this topic HbA1c later in detail, but we understand that a glucose lives in an RBC and the roommate of RBC there, roommate of the glucose there is globin. A combination of globin with glucose is glycosylated hemoglobin, HbA1c. That is more than 6.5%. Okay, so diagnosis wise, HbA1c more than 6.5%, oral GTT cutoff 200 after 75 gram of glucose load, fasting sugar more than 126, symptoms with random blood sugar more than 200. Okay, so either of the four can qualify for a diabetic patient. Now, how to monitor diabetes? A very important thing again, monitoring of diabetes. Monitoring of diabetes can be done by fasting sugar or by PP sugar. Better tool clinically would always be a fasting sugar. For one reason, postprandial sugar highly subjective. Patient goes and have a breakfast. He takes a heavy breakfast, his sugar will go high. He doesn't take 75 gram, he takes 750 gram sometimes. So postprandial sugar is highly subjective, fasting sugar is more reliable. But better reliable things that you need to consider in the patient is glycosylated hemoglobin, a value of HbA1c. A combination of globin with a glucose is known as glycosylated hemoglobin. I recall that this globin is in the RBC and RBC stays alive with me for duration of 90 days. So it basically reflects a sugar control over 90 days. Reflects a glucose control or a sugar control over 90 days when the RBC is actually alive. So it basically gives me an information of a long-term control. So long-term control of diabetes is looked into by a HbA1c assay. Something that has been proved by various studies that a good control of diabetes means that HbA1c is less than 7%. For diagnosis of diabetes, it has to be more than 6.5%. For a good control, it is actually less than 7%. Ideally, as Harrison writes, in a year, 2 to 4 times you should get an HbA1c assay done for the patient. At least twice minimum you should get an HbA1c done for the patient. Second assay that can be done in the patient is serum fructosamine assay. Fructosamine assay is basically a quantification of fructose, that is a sugar, with amine, that is albumin. So it basically reflects a control over 40 days, over 14 days. Why? A protein or an albumin stays alive for 14 days. So you give me a sense of a short-term control. So short-term control from fructosamine assay. Like I shift a patient from insulin to OHA. After 3 weeks time, I want to see how 2 weeks the patient was. What do? I do a fructosamine assay. After 3 months, I do an HbA1c assay. But in clinical practice, there is no study and data to tell me what is the normal serum fructosamine assay that you need to look into the patient. So we don't get a fructosamine assay very often done. We get an HbA1c for every diabetic patient. So HbA1c was for control and as well as for the screening of diabetes both way. Okay. Now an acute complication of diabetes, especially a type 1 patient, that is diabetic ketoacidosis, well abbreviated as DKA. He is a diabetic patient who is a type 1 diabetic very often. So it's a saying that ketone bodies are more often seen in type 1 patient, not in type 2. Remember one thing, ketosis occurs in type 1 patient, not in type 2. Okay. Random blood sugar is more than equal to 250 milligram per deciliter. First definition criteria for DK. Second, ketone bodies. Ketone bodies can be seen in the blood, can be seen in the urine. If at all they are seen in the blood, the word that we use for them is ketonemia. If at all it is seen in the urine, the word that we use for it is ketonuria. Something that we learn from biochemistry, ketone bodies in the blood are more reliable an indicator as compared to the urine. Because we teach in biochemistry that ketone bodies in the blood come and fall as per the disease process. So some one-liner question, more reliable test for diagnosis of DK would always be a ketonemia as compared to a ketonuria. But I will like this question as best bedside test is often a ketonuria. It can be done bedside, doesn't take the urine sample to the lab. It's a ketone stick that is available with us like a litmus paper strip. You dip it in the urine sample, changing color, ketone body present, no changing color, ketone body absent. Now some questions from biochemistry. Ketone bodies are of 3 types actually. Here we know that beta hydroxybutyrate, BHB, is 3 times of acetone, acetoacetate. So which ketone body is measured in urine? Tell me this answer. Do you measure the beta hydroxybutyrate or do you measure the acetone? Right, B or A? A for acetone, B for beta hydroxybutyrate. A very simple question. Clinical sample when is given to you for urine for estimation of ketone bodies, what do you measure? Do you measure beta hydroxybutyrate or do you measure acetone? I agree with you that beta hydroxybutyrate is more in amount, but in urine sample we always measure the acetone. Remember this. Okay? So ketone bodies in urine, what we measure is actually acetone, acetoacetate. Okay, we measure that one. But more amount what we have in blood and urine is always beta hydroxybutyrate. But the commercial kit that is available for urine estimation measure the urine acetone, urine ketones or urine acetone. And the third criteria that need to fulfill is low pH, metabolic acidosis. So in patients with DK you get an ABG done, arterial blood gas analysis. In that patient you get a low pH, metabolic acidosis. Okay. So these are few important steps how to recognize a patient biochemically as DK. Now how to recognize a patient clinically as DK? Clinical features. Clinical features: nausea, vomiting, abdominal pain with or without tenderness, with increase in the heart rate and increase in the respiratory rate. A very important statement. Tachypnea occurs not due to abdominal pain. Basically, if the patient is having metabolic acidosis, what will happen? The body will have compensatory respiratory alkalosis. For creating alkalosis in the patient, you drive out the carbon dioxide from the respiratory tract. In that attempt, you have tachypnea. But the unfortunate part is that if a patient comes to my casualty with all these symptoms said in front of me, nausea, vomiting, abdominal pain, tenderness, tachycardia, tachypnea, I don't see him as a case of DK. Unfortunately, I see him as a case of surgical emergency. Pancreatitis, cholecystitis, perforation, peritonitis, blah blah blah. I may send him to a surgeon who may do a surgery also on this patient. Problem. So it's very important to recognize this patient and keep it different from surgical emergency. One important symptom that may emanate in the breath of the patient is because of the acetone. That is a fruity odor. So in the patients with DK, very often they have got a fruity odor. And the death factor happens because of this phenomena, dehydration. So in these patients of DK, we find a very severe form of dehydration is seen. They only puke out once or twice, but in these patients they have a very severe form of dehydration. Remember one way, D for death and D for dehydration in the patient. Treatment. Treatment should always start with something that will correct the hydration first. Always an IV fluid. The IV fluid of choice is normal saline, 0.9% saline, isotonic saline, a saline which is as same as the blood. But I realized that after few hours, the DK problem was dehydration. In dehydration, serum osmolality will go up, sodium will go up, and will the chloride also. If I give him sodium and chloride together, 0.9% sodium chloride, I may increase the sodium, I may increase the chloride level. It becomes a problem. So immediately after 4 to 6 hours of therapy, I change it to half normal saline, 0.45% saline, just to prevent the risk of hypernatremia and hypercholelemia in the patient. Then I realize everything that is going on is catabolism. Patient requires some energy. I give him 5% dextrose. A 5% dextrose solution is given to the patient when the random blood sugar dips below 250. Above 250, if the RBS is there, you give dextrose. That may increase the sugar, may create more problem. So it has to be given when the random blood sugar dips below 250. Something which the book classically tells me, all the emergency guidelines tell me, when the patient of DK is diagnosed, please give 4 to 6 liters of fluid. Because at the time of diagnosis, this is much amount of fluid deficit is already there. And give it as rapidly as possible. If you read any book of how to manage patients in ward, like clinical books, they keep on telling you in DK, you give 1 liter in first half an hour, 1 liter in next half an hour. You keep on giving as rapidly as possible, as genuinely as possible. Now the thing is that the sugar control is also necessary, and you start your therapy with an insulin. Insulin. If I divide insulin, I divide it on the duration and onset of action. One is an ultra short acting insulin, that is Lispro and Aspart. One was a short acting insulin, regular insulin. Other one was NPH lente, intermediate acting, and long acting glargine and detemmer. But the insulin here should be one which is not only given subcut, it is given IV also. All the insulins are given subcut. One insulin can be given subcutaneously in IV, that is a regular insulin. The word regular insulin in the book is also known as soluble insulin. It dissolves in blood very often. The regular insulin is given at a dose of 10 unit IV bolus initially, and then happily as an infusion of 0.1 unit per kilogram per hour. Number 3. I realized that the patient of DK is getting insulin. Insulin is shifting the glucose into the cell. Simultaneously is also shifting the potassium. So we need to replenish potassium in the patient by KCl. Potassium chloride is given at a dose of 20 to 40 milliequivalent per hour infusion again. Now I realize one basic thing, that the whole drama is acidosis. So I give him some alkali, soda bicarb, bicarbonate therapy. Bicarb therapy is not given every time. It is given when the pH is extremely low, less than 6.9. Normal pH of the blood, if I remember, is 7.34 to 7.43, 34 to 43, in a range of 7. Now the pH is very low, then we give a bicarb therapy. We learned this from clinical practice. Giving bicarb might kill the patient. I'll tell you, a patient of renal failure is in 24 hours metabolic acidosis. A nephrologist checks upon him, never gives him bicarb. He tells you, don't give bicarb, I'll do dialysis, that will be better. One reason, giving bicarb can cause cerebral edema and myocarditis. So it becomes more of a poison than a drug. Okay, so bicarb therapy less than 6.9. And we learned this from clinical practice. If I give IV fluid, if I correct the sugar, I get potassium, acidosis will also correct accordingly. Okay, so this is a lucky 4 for a patient of DK. Note down a question on this. First, a very simple one. Most effective therapy for DK. Option A, IV fluids. Option B, insulin. Option B, bicarb therapy. Option D, potassium chloride. Tell me an answer for this. Good. At least I'm happy you understand this biased question. This is a question from the National Board again, a biased question. Most effective therapy. Not insulin. Correcting the sugar level won't save the life of the patient. The patient dies of dehydration. You need IV fluid. Most effective would be the one which could save the patient's life. That is obviously an IV fluid. Unfortunately, in your guide, the answer is insulin. He doesn't realize that point, that IV fluids will save the life, not the insulin. Okay. So most effective therapy is always IV fluid, something which will save the life of the patient. One more question. Concerning DK, which is correct? Option A, fluid replacement should start with 0.45% saline. Option B, 20 units of regular insulin is given subcutaneously. Option C, if pH is less than 7.1, the bicarb are replaced. Option D, 5 to 6 liters of fluid deficit is seen at the time of diagnosis. Rhythm correct? You never start the replacement of fluid with 0.5%, you always started with 0.9% saline. 10 unit is given IV. pH is actually close by. You might be thinking that C may also become a correct answer. No. pH is less than 6.9, then you start the bicarb. And at the time of diagnosis, there is a negative balance 5 to 6 liters. That's why 4 to 6 liters of IV fluid is given as fast as possible. Okay. Second disorder that you possibly see in a type 2 patient is hyperosmolar non-ketotic coma. Hyperosmolar non-ketotic coma. This is seen in patients with type 2 diabetes. What happens in type 2 diabetes? The blood sugar level is in a range of 600 to 1000 milligram per deciliter. Okay, it's very high. Secondly, these patients are non-ketotic. They lack the ketone bodies. And the word is hyperosmolar. Because of the high blood sugar, the serum osmolality is also very high. They got a high serum osmolality. So the sugar is very high, ketone bodies are not seen, and they have got a high serum osmolality. And coma. These patients have got altered sensorium. So these patients of type 2 diabetes has a very high blood sugar between 600 to 1000, lack of ketone bodies with a high serum osmolality, and of course an altered sensorium. Coma. Treatment. Such a patient requires an IV fluid. Yes. The IV fluid replacement rate is even higher. IV fluids are given at a rate of 6 to 10 liters. A very high amount of IV fluid is given with an intention. If the serum osmolality is very high, I give a fluid to the patient that will dilute the plasma, will decrease the serum osmolality. So IV fluids are happily given at a rate of 6 to 10 liters, a very higher amount of IV fluid. Number 2, you can give insulin to the patient, of course, anytime. So the only difference between DK and hyperosmolar coma is hyperosmolar coma is seen in type 2 patients. They have a blood sugar very high, ketone bodies absent, serum osmolality high with an altered sensorium, and the correction rate of IV fluid is even higher, 6 to 10 liters. A question on this, a very simple one, write it down. RBS in hyperosmolar coma, same IV fluid per 9% saline, is mildly raised, moderately raised, highly raised. Tell me, RBS in hyperosmolar coma is mildly raised, moderately raised, or highly raised, or severely raised? C. Severely or highly raised RBS. Simple answer. Now we shift our frame onto chronic complications of diabetes. That is one of them, a very famous one, diabetic neuropathy. Diabetic neuropathy. The very type that we see very often in the clinical practice is that the many nerves are involved, known as polyneuropathy. Many nerves are involved, polyneuropathy. And the type of diabetic neuropathy or polyneuropathy that you see is distal, symmetrical, sensory neuropathy. The most common type of diabetic neuropathy that you clinically see is distal, symmetrical, sensory neuropathy. The word is distal and symmetrical on both the side and on the end, distal. That's why I remember something from my MBBS days. These patients have got a glove and stocking kind of sensory loss. Gloves are in both the hands, symmetrical, are in the hand, not on the shoulder, distal. That's why in surgery I read a topic of diabetic foot, because the story is distal. I don't read a topic of diabetic thigh or diabetic abdomen, because the story is not often proximal. Problem. In Harrison there are two lines. One line tells me that the most common type of diabetic neuropathy is distal symmetrical sensory, while in peripheral neuropathy chapter he tells me it is sensoromotor neuropathy, most common. No, it is sensory. I have cross-checked in every journal and other higher books of diabetes. It is often a sensory which is most common, not sensoromotor. Now first sensation to get lost is the vibration sensation. Fine. Vibration sensation you tested with a tuning fork. Yes. The frequency of tuning fork that you use for testing the vibration sensation is 4 options: 128, 512, 256 or your 1056 or 10 something. I don't remember the frequency. Tell me an answer for this. A, B, C or D. I want to, God. My dear friend, answer is 128, clinical neurology. 128 is better felt than heard. You don't use it for Rennies and Webers, you use it for vibration sensation. For 128 Hz frequency tuning fork is used for testing the vibration. It is not the 512, 256 or even 1000 wala. Okay. Now the story is like this in a patient with polyneuropathy. Firstly, patient experiences tingling and numbness. That is known as paresthesia, and over a period of time they have loss of sensation that we recall as anesthesia. So in tingling numbness, positive symptoms, paresthesia, loss of sensation, anesthesia. Treatment. If I want to treat a patient with diabetic polyneuropathy, the first thing that I do is improve glycemic control. I think I will correct the sugar, the things will correct? No. I've seen a patient of diabetic foot, anesthesia. That patient, even after correction of sugar, did not have an intact sensation. Sensations are totally lost. Even a patient with paresthesia, even after control of blood sugar level, his paresthesia remained there with the patient. So we understand that improved glycemic control doesn't improve the symptom, but may decrease the progression. So things from paresthesia won't go to anesthesia if your sugar level is controlled. Okay. Second, to control the paresthesia, we have got certain drugs which are anti-epileptic drugs. Okay. I'll give you 4 options. Tell me which anti-epileptic should be used in a diabetic patient. Drug of choice, anti-epileptic. I'll give you 4 options. Carbazepine, gabapentin, phenytoin, and pregabalin. Drug of choice for painful diabetic neuropathy. I knew this half knowledge is always dangerous. Many of you answered it as gabapentin. This is not very clear in Harrison, but a recent update article on this, carbazepine was the first drug which was used, but carbazepine a side effect or problem. Phenytoin should not be used idly because it can lead to hyperglycemia itself. Around 2 years back the answer was gabapentin, but this year the answer has changed, pregabalin. Now gabapentin is no more used as a drug of choice for painful diabetic neuropathy because gabapentin often causes a lot of sedation in the patient. Pregabalin, less sedative a drug, equally effective as gabapentin. So the answer for drug of choice this year is not gabapentin, it is now pregabalin. Okay. Number 3. You can also use a drug which will inhibit the painful sensation, tricyclic antidepressant, amitriptyline. So amitriptyline is a tricyclic antidepressant that is used in patients with painful diabetic neuropathy. Number 4, we can also give a nerve regenerator to the patient, that is methylcobalamin. So nowadays, around a year back, we were all giving multivitamin preparation to the patient for nerve regeneration. But nowadays we are adding this multivitamin with pregabalin. So most of the multivitamin that are used in diabetic patient are having pregabalin with methylcobalamin, a nerve suppressor and a nerve regenerator, a better therapy. Second neuropathy that you typically see in patients with diabetes is mononeuropathy. Only a single nerve is involved, mononeuropathy. Most common cranial nerve involved in diabetic neuropathy, okay, is, tell me an answer for that. I think so you forgot my first class. I've already answered this question correctly there. It is third, my dear friend, it is third. Okay. Tell me one more answer. Most common cranial nerve involved in aneurysm is sixth, third in aneurysm. Berry aneurysm. Sixth. Arey yaar. Third, in patients with raised ICT, sixth, in patients with raised ICT, sixth, In patients with GBS, 7th. Longest intracranial course, 4th. That's how I tell you, you guys temporal lobe is perfect, medial lobe, immediate short-term memory, but your long-term memory is very bad. Your hippocampus is always bad. So whatever you read, please go back and revise to sharpen up your hippocampus at least. Okay. Now in this topic of diabetes, there is a controversy. Diabetic chapter, Harrison, mentions that the most common kidney nerve involved in diabetes is 3rd, but the peripheral neuropathy chapter mentions the answer is 7th. Problem, controversy in Harrison itself. Harrison is not wrong in the sense, what happened was, most common cranial nerve to get involved, I already mentioned this answer as 7th. Bell's palsy, idiopathic 7th cranial nerve palsy, 50% of the patients were found to be diabetic. So they thought that in diabetes, it was the 7th cranial nerve. No, it is still the 3rd, number 2 is not 6th, number 2 is 7th. Okay, so 3rd and 7th, you can write in a bracket 7. Something important about diabetic mononeuropathy, 3rd cranial nerve palsy, these patients will have ptosis, ophthalmoplegia, but pupillary reaction is perfect. Pupillary sparing is seen in the patient. Okay. Number 3, the most catastrophic of all, autonomic neuropathy. Why I tell the word most catastrophic? You and me don't eat anything for 6 hours maybe. We don't eat, we stay in a fasting, maybe 12 hours, 24 hours. We start eating after 12 hours or 24 hours. Why? Because you will get a hunger pang in your stomach. You'll have a dryness of your mouth. You'll have tachycardia and you'll have sweating. Hypoglycemia, all symptoms that I've talked about come from an autonomic system. Parasympathetic increases the sweating, sympathetic increases the heart rate and causes dryness of the mouth. So it has been said in the book that a diabetic patient in a life will go into hypoglycemia at least twice. If he or she knows it is hypoglycemia, they will eat something at home, and now they will give something at home, they will eat something at home, and they will never come to the hospital even. They don't require an hospitalization. Because the patient eats something, recovers from that. Because the patient had a symptom. He knows it, he has hypoglycemia. But if the patient is suffering with autonomic neuropathy, parasympathetic and sympathetic system is not working at all. As a result, what will happen? He or she will get low blood sugar, will not realize it. They will have hypoglycemia, will be unaware of it. So autonomic neuropathy is more catastrophic for one reason. These patients have got hypoglycemic unawareness. So for such a patient, what do? We don't do this intensive control. The word intensive is strict control. A patient has got a blood sugar 140. A good control, intensive control. For that, patient should take insulin, should exercise, should not eat this. If it is 140, alright. Suddenly because of intensive control, it becomes 40. What will happen? Hypoglycemia. If the patient knows about it, he'll eat something, doesn't require even a hospitalization. If the patient is not aware of it, he or she will fall unconscious, may die also. So that's one reason intensive control is avoided. Because intensive control increases 6 times the risk of hypoglycemia. So there are 6 times the risk of sugar instead of 140 going to a level 40. Patient knows it, eats something, doesn't require hospitalization, doesn't know it, falls unconscious and may die. So that's one reason in a patient who is suffering with diabetic neuropathy, autonomic neuropathy, you don't advise for this intensive control thing because it will become more of a risk, less of a solution. Chalo, write down this question. Which of the following is not true about diabetic neuropathy? Which of the following is not true about diabetic neuropathy? Oh, okay, sorry. I'll put it like other way around. Which of the following is true about diabetic neuropathy? Option A, autonomic neuropathy is most common type. Option B, all cranial nerves are equally involved. Improved glycemic control will not affect the symptoms. Alcohol is used in treatment. Very smart. Which of the following is true about diabetic neuropathy? Jammu Center, alcohol is used in treatment. Rhythm correct. Autonomic neuropathy is not the most common type. It is distal symmetrical sensory neuropathy. All cranial nerves are not equally involved. Third is the most common. Number 2 is 7th. First the third, number 2 7th. Improved glycemic control will not affect the symptoms. That's correct. It may stop the progression of the symptom, but paresthesia and anesthesia will remain there. That's why in clinical practice we add an anti-epileptic drug. Alcohol is used for treatment of diabetes. Oh, 2 pegs a day keeps the doctor away. Maybe that way. Now another question. Note it down. Another typical question that we saw in the book was this. In which of the following intensive management of diabetes is needed except autonomic neuropathy, pregnancy, post kidney transplant, DM in acute MI. This is another one question that you will find as a discrepancy in both the guides, AA and MK, Mudit Khanna and Amit Ashish, two different answers. Good. Rhythm correct. Autonomic neuropathy will actually have, I'm waiting for D. I was waiting for D. Someone to answer as D. I'll tell you why not D. Autonomic neuropathy is bigger a problem because in autonomic neuropathy the patient has got hypoglycemic unawareness. In intensive management there are 6 times risk of causing hypoglycemia. Patient already doesn't know it is hypoglycemia, may fall unconscious, may die. So intensive management is not needed for them. It is actually avoided for them. Pregnancy, always in intensive management. We remember that in GDM female, gestational diabetes, we keep the blood sugar somewhere at 105 plus minus 5. We never let it go beyond 140 because an RBS status in female in pregnant state beyond 140, especially the postparental, will cause macrosomia and congenital heart defect. That is a definition for GDM. Post kidney transplant, the most important, because you've done a kidney transplant, you give an immunosuppressant agent so that the graft doesn't get rejected. Immunosuppression will cause an immunocompromised environment. If the sugar is high, an opportunistic infection can anytime flare up there, will kill the patient. One guide gives the answer as DM in acute MI. Remember one thing, whatever you read in the guide is not correct statement. Listen to his confabulation. He tells you intensive management of diabetes will not benefit the acute MI. That's how you don't do an intensive management for such a patient. Very smart. Yes, he's correct. Because if a patient comes to me with acute MI, I don't give him 10 units of insulin and after 1 hour I start thrombolizing the patient as if his sugar control will revert the MI. No. As a clinical sense, you should realize that acute MI is a stressful state. It will release catecholamines that will increase the blood sugar. Blood sugar beyond 250, DKA, beyond 600, hyperosmolar. Every time the number one treatment is IV fluid. It's very difficult for managing a patient on IV fluid with acute MI. In acute MI, just to prevent a back problem or a complication of diabetes, we maintain an intensive management. It is not actually benefiting the acute MI directly at one go. So DM and acute MI intensive management is done, but autonomic neuropathy, we don't do it. Answer is A. Regarding diabetic retinopathy, you read in I. Regarding diabetic nephropathy, you read in your kidney chapter. More important was diabetic neuropathy. Now we'll move in the opposite direction, that is hypoglycemia. Hypoglycemia definition in clinical medicine, at least what I know, is not on the level of sugar, is at the level of symptoms. I remember hypoglycemia can be very well defined on this, which is known as a Whipple's triad. Whipple triad defines hypoglycemia very well. A love triangle again. Signs and symptoms of hypoglycemia. Number 1. Number 2. Documented hypoglycemia. And the third most important thing, reversal of symptoms on correction of hypoglycemia. That's the most important thing again. Like if a patient comes to me unconscious, I check his blood sugar low, I give him dextrose, still he doesn't recover. It's not a case of hypoglycemia, it is something adding to that unconscious level. Maybe a pontine hemorrhage, maybe anything else. But if a patient comes to me with signs and symptoms of hypo, I document it as hypoglycemia and I give him dextrose and he becomes totally normal. That's a hypoglycemic episode. The textbook Harrison tells me that the blood sugar level, if it is less than 55 milligram per deciliter, that's a diabetic hypoglycemic attack. So hypoglycemia will come into the picture in adults when the blood sugar is less than 55. Now the thing is that whenever a hypoglycemia occurs, the very first thing that happens is decrease in insulin. Number 2 would be a counter-regulatory system, increase in glucagon. And number 3, all the friends together. An increase in cortisol, an increase in epinephrine, an increase in growth hormone, in this particular order. So that was an easy question. That first step that takes place in a hypoglycemic patient is decrease in insulin. First counter-regulatory hormone that steps up, it is not cortisol, it is glucagon. Now the funda is that you sit on a hunger strike for a long time, 2-3 days, okay, you never develop hypoglycemia because the system is very perfect in you. Insulin will come down, glucagon will go up, you are awake, cortisol and epinephrine will help you. When you are sleeping, growth hormone will help you. So that's a normal compensatory mechanism. We don't get hypoglycemia so very often because these counter-regulatory steps are very helpful. But the very first step, decrease in insulin, doesn't happen. I found a patient of hypoglycemia in which the sugar was low and the insulin was high. So if the insulin is high causing hyperglycemia, I know this problem as hyperinsulinemia. The problem is within my body. I know the word as endogenous. There are 2 reasons for that. One, rare disorder, that is a tumor in the beta cell, insulinoma, and more common than that, a drug that the patient often takes, secretagogue, sulfonylurea. Now the thing is that the problem is within the body. If the insulin comes out from the beta cell, a friend also comes along with that, that is C-peptide. So in problems within the body, I see a rise of insulin and a rise of C-peptide. There are two reasons, insulinoma and sulfonylurea. Insulinoma are very well diagnosed radiologically, and a chapter of insulinoma in Harrison tells you one thing: insulin glucose ratio is more than equal to 0.3. So in patients with insulinoma, we found that the insulin was very high and the glucose was very low, and the ratio was found to be more than 0.3 in patients with insulinoma. While sulfonylurea patients, you need to get the sulfonylurea levels done, because sometimes the patient doesn't give you a history about that. You get a sulfonylurea levels done, you have an idea about it. Second reason is exogenous, outside the body. More common because the patient accidentally takes insulin or maybe takes a higher dose of insulin from outside. So if the insulin from outside increases, I believe only the insulin will rise, not the C-peptide. So that's the thing that you need to remember. If the patient comes to you with hypoglycemia, his insulin is only high, the problem is exogenous, outside insulin. If the problem is endogenous, insulin and C-peptide both are proportionally high. Okay. Now the thing how to diagnose this patient is to make them fasting. We tell them not to eat for 72 hours. Normal fasting 8 hours up till 12 hours up till 24 hours is still okay. Beyond 24 hours they will have hypoglycemia. So we tell them to fast for 3 days, 72 hours. I put the word as extended fasting. So I tell them to remain hungry and not eat anything for maybe 3 days. And after first 24 hours we see hypoglycemia. Okay, we see hypoglycemia, you draw the blood sugar sample. At the same time you draw the insulin and the C-peptide sample also. If the sugar is low, insulin and C-peptide are high, it is a problem which is known as endogenous. If the sugar is low and only the insulin is high, the problem is known from outside, exogenous. So for diagnosing such a patient, you subject them for extended fasting. As soon as the blood sugar comes down, you check the insulin level. Normally it should be low, it was high with C-peptide endogenous, only insulin high, exogenous. Now one more disorder, two more disorders actually, which we see in a connection with hypo and hyperglycemia in diabetes. One of them very famous, Somo-Guy effect. Somo-Guy effect. You know what happens in the 3 to 5 a.m. time after midnight, when the patient is possibly at the deepest of his sleep. At that very moment of time, patient finds hypoglycemia. During sleep, hypoglycemia. Okay. I believe if the patient gets hypoglycemia, the first step is decrease in insulin, second step is increase in glucagon, third is cortisol, epinephrine and growth hormone. Unfortunately, everyone is sleeping. Who is remaining awake after till midnight is a growth hormone. And because of the counter-regulatory hormone, especially the growth hormone, what happens? Morning 8 a.m. I check the sugar of the patient, 8 a.m. It is found to be high, hyperglycemia. So we have got a patient who has got hypoglycemia followed by rebound hyperglycemia. The story is known as Somo-Guy effect. Okay. You know, the normal tendency clinically, when I see a morning sugar being high, I increase the night dose of insulin. I keep on increasing the night dose of insulin. Patient keeps on going to hypo and rebound hyper. Hypo followed by hyper because of the counter-regulatory hormone is known as Somo-Guy effect. Now what happens? Why hypo? Because the night dose of insulin that I gave to the patient was high. Instead of 10 units, I gave him 20-25 units. It was high. It went inside, caused a hypo, followed by rebound hyper. Somo-Guy effect. Treatment. If I am able to well document this kind of an error in the patient, what do? I decrease the night dose of insulin. I decrease the night dose of insulin. Okay. So in such a patient, I decrease the night dose of insulin. Other similar kind of a story is dawn phenomena. In the 3 to 5 a.m. time, again in the morning after midnight, patient has developed hyperglycemia. Why? Because the insulin that you gave was less, patient had insulopenia, lesser insulin. And secondly, the insulin could not act on the peripheral tissue, insulin resistance. As a result, 8 a.m. in the morning, I saw the blood sugar of the patient. Again, it was high. So after midnight high till morning high, the story is known as dawn phenomena. Okay. For treatment of such a patient, I increase the night dose of insulin. I'll do it the other way around. I'll increase the night dose of insulin so that the amount of insulin is okay. It's not insulopenia, and the amount of insulin is able to bring the glucose into the cell. There is no insulin resistance. So initially low, then high is sumogai. All the time high is dawn phenomena. Now $1 million question: how to manage a patient who is having type 2 diabetes? A consensus on this is on a fasting blood sugar level. They write in the book, Harrison, not in the table this time, in a paragraph form, that if the fasting blood sugar at the time of diagnosis is in a range of 126 to 200, then in that case you just take care of the diet and the exercise. If the fasting blood sugar is in a range of 200 to 300, and if the patient is obese, then I remember from pharmacology, drug of choice is metformin. Why? Metformin, I remember from pharma days that it's a biguanide. It is actually an insulin sensitizer. So in obese patients, the insulin resistance is the major cause of the disorder. So you give an insulin sensitizer, patient benefits. Obese patient, metformin. While on the other end, the non-obese, drug of choice is sulfonylurea. Why? Non-obese patient, the main cause is secretory defect. Sulfonylurea are secretogogues. They will push out the insulin from the beta cell. So that's why in non-obese, drug of choice is sulfonylurea, while in obese patient, the drug of choice is metformin. If the fasting blood sugar any time, maybe at the diagnosis very often, is found to be more than 300, then drug of choice is simply insulin. For one reason, the body doesn't have a store of insulin. Beta cell mass is 90% destroyed. Although the patient is type 2, but he doesn't require a OHA. OHA will act when the beta cell is alright. This time it is only the insulin that could really benefit the patient. Okay. Write down 2-3 questions on this. Treatment of 42-year-old obese male with a random blood sugar of 450 mg per deciliter, urine albumin of 2 plus, urine ketone 1 plus, A. Insulin, option B. Glibenclamide, option C. Glipizide, option D. Metformin. Obese patient, type 2 patient, maybe beyond 40 years, urine albumin plus, ketone 1 plus. Half knowledge is always dangerous. Obese, type 2 diabetic, drug of choice, metformin. Why not metformin? Why insulin? You know, metformin, if you read in pharma, is a biguanide. It has got one serious side effect, lactic acidosis. If you look into the question, urine ketone is positive. Lactic acidosis by metformin, already ketosis, patient will go into decay then. Problem. So never give metformin to such a patient. Give simply insulin. That will control the blood sugar so well as compared to even metformin. Okay, that's the answer for that. Another question. An obese type 2 patient who has got a fasting blood sugar of 180 and a postparental blood sugar of 260. Treatment. Option A, glibenclamide. Option B, metformin. Option C, diet and exercise. Option D, insulin. Half knowledge again dangerous. Obese type 2 diabetic patient, drug of choice metformin. My dear friend, the question is fasting 180. You manage a type 2 diabetic patient with a fasting sugar. Fasting between 126 to 200. Don't give metformin so early. Just treat him on diet and exercise. That will be the best answer, not metformin. Metformin will come into the picture when the fasting sugar is beyond 200. Okay? You start your therapy with diet and exercise, wait for 2 weeks, and then if the patient doesn't improve, then you may add something. Okay? Don't start with metformin. Only diet and exercise as per the literature. Now we'll consider the discussion on another endocrine topic. That is again an overlap between me and the surgeon. Thyroid disorder. Thyroid disorder. If I look at the thyroid disorders, why does a thyroid disorder occur? Because there is a pituitary gland that controls the thyroid gland below it by a stimulation variable that is known as TSH. Okay. Because the thyroid gland has a capacity to produce a thyroid hormone in a form T4 that converts itself into peripheral stream into T3. Okay. So there is a regular conversion of T4 to T3 in the peripheral bloodstream. Why? Because we know this from physiology, the inactive form of thyroid extract is T4 while the active form of thyroid extract is always T3. A conversion of T4 to T3, 4 to 3 means a loss of iodine because most of this thyroid hormone is formed from iodine molecule. You lose 4 to 3, you lose 1 iodine by enzyme that we know as 5-D iodinase. Who can do it very often? One of the very famous drug, that is a beta blocker, propranolol. Second one is an anti-thyroid drug, propylthiouracil. Third one can be a steroid even, dexamethasone. And the fourth one could be a high dose of iodine that the patient gets. This high dose of iodine can come through radioiodine, or it could be possibly a oral or Lugol's iodine even. So this thing from pharmacology was very important because a patient who suffers with a problem, thyrotoxicosis crisis, hyperthyroidism to a very severe extent, thyrotoxicosis, into a bad shape crisis. This time the hyperthyroidism has taken a toll on the heart, on the brain. So it becomes a crisis for the patient known as thyrotoxicosis crisis. So for managing a patient out of that thing, we have got propranolol, PTU, Dexa and Lugol's iodine. A very simple question that we had faced that few years back. Drug of choice for thyrotoxicosis crisis. We have got 4 options. A, propranolol, B, PTU, C, Dexa and D, Lugol's. Give me an answer for this one. Drug of choice for thyrotoxicosis crisis. We got 4 options. Lugol's, PTU, Dexa or propranolol. I was waiting for someone to answer me as Lugol's because surgery guide answers that Lugol's. The answer is not very clear in the Harrison at least, but in surgery book they write it like this. Like a patient of thyrotoxicosis crisis doesn't die of crisis, he or she dies of arrhythmia. Preventing an arrhythmia, treating an arrhythmia, preventing tachycardia is very easy with propranolol. So drug of choice award should go to a drug which will save the life of the patient instantly. The answer is propranolol. But if the question got changed, anti-thyroid drug of choice, I'll mark it as PTU, not carbimazole, metamazole. but never a Lugol's iodine, because Lugol's iodine as compared to propranolol and PTO is highly not very quickly and it's not very effective. Okay, so drug of choice is propranolol if given an option between the four. Now this T4 and T3 don't roam around here and there on their own. They roam around everywhere on a scooter. The name of that scooter is thyroid binding globulin, a transport protein. Sometimes in clinical practice we see that the thyroid bind. Now that's the relevance. T4 and T3 are of two types. One which is bound to TBG and one which is away from TBG, free form. Bound form is the inactive form and the free form is active form. So if at all you want to get it done, a test, you please get a free T3 and a free T4 done for the patient rather than just getting a T4 and T3 done. A very interesting question at this point, write it down. Best test to diagnose thyroid related disorder. TSH, T4, T3 or thyroid binding globulin. Best test to diagnose thyroid related disorder. ABCD. Always a TSH. You never rely on T4 and T3 because the free value will change as per the TBG. Okay. Now the thing is this, there's one clinical situation in which the TBG often rises. I remember that situation in which the TBG rises is pregnancy. If the TBG rises, the bound form will rise and the free form will dip. So there is a dip in the free T3 and free T4 value that results very often in hypothyroidism. And a word that we use very often during pregnancy, maternal hypothyroidism. So during pregnancy we saw diabetes, gestational diabetes, GDM. During pregnancy we saw hypertension, PIH. Now during pregnancy I see hypothyroidism, maternal hypothyroidism. It's a very physiological thing. TBG rises, that dips down the free T3, T4, that affects hypothyroidism. Okay. Now we'll play the game of negative and positive feedback. Okay. There is a pituitary gland, there is a thyroid gland. Pituitary sends down a stimulation, TSH. Thyroid gland brings out T4 that acts on the peripheral bloodstream in T3 form. So we'll draw a table with 4 vertical columns. TSH, free T3 and free T4. If by any chance the free T3 and free T4 is less, positive feedback, TSH will rise up. The story is known as hypothyroidism. Thyroid gland is not working. Due to some reason, free T3 and free T4 is high, TSH will come down, negative feedback. We understand the word as hyperthyroidism. But we have seen a disorder in which the TSH was less, free T3 and free T4 was also less. The word is again hypothyroidism, but now the terminology is different. If the gland is unable to form the hormone, the word is primary. If the pituitary gland is unable to stimulate the thyroid gland, the problem is known as secondary. Till now the problem primary and secondary solution, but now the nomenclature in thyroid disorders is slightly different. If the gland is unable to form the hormone, that is primary. If the pituitary gland is unable to send down a stimulation, it is secondary. And by chance if the hypothalamus doesn't stimulate the pituitary, the problem is in the big boss, hypothalamus. Then I'll put the word as primary, secondary and tertiary. So this is how we divide the thyroid disorders. Primary, a problem in the gland. Secondary, a problem in stimulation. A problem in the big boss, tertiary. So the last one in the list is secondary hypothyroidism. And first one in the list is primary hypothyroidism. Okay. Now clinical features. If I look at the disorder hypo versus hyper, clinical features, hypothyroidism versus hyperthyroidism. Okay. Hypothyroidism patients are having a lot of fatigue, weakness, while patients of hyperthyroidism on the other end are having a lot of anxiety. A patient of hypothyroidism often complain of weight gain. A patient of hyperthyroidism often complain of weight loss. So they are obese and they are thin. A patient of hypothyroidism often complain of constipation, while hyperthyroidism often complain of diarrhea. Patients with hypothyroidism feel cold a lot, cold intolerance, while hyperthyroidism have got heat intolerance. Patients with hypothyroidism, especially in the female population, can have one menstrual abnormality you talk about, menorrhagia, while hyperthyroidism often have got amenorrhea. If I look at the signs in the patient, patients of hypothyroidism often have got bradycardia, while hyperthyroidism have got tachycardia. Patients of hypothyroidism have got mild diastolic hypertension. This was a question this season on All India Pattern one-liner. Which kind of hypertension is seen in hypothyroidism? It is a mild diastolic hypertension. While in hyperthyroidism, it is both systolic and diastolic. Now the thing is that a patient with hypothyroidism will have one thing clinically on a neurological examination, that is known as delayed relaxation of a particular jerk. Like I was doing an ankle jerk. If I see the foot, I strike the foot with a knee hammer, I take the foot up, I take the foot down. That is a normal ankle jerk. It goes up and it comes down like this, ankle jerk. But this time the coming down is very slow. There is a delayed relaxation of this ankle jerk. That is known as a hung up reflex. So that was a famous question, one-liner pattern. That hung up reflex is suggestive of hypothyroidism. That means a reflex that is hung up is getting relaxed very slowly, delayed relaxation. While checking an ankle jerk, the foot dorsiflex and then plantar flex. Coming down to the plantar flexion takes a lot of time. That is known as delayed relaxation of jerk. While in patients with hyperthyroidism, one of the very classical things that we see are tremors, which are very small, fine tremors. And they also show bulging of the eyeball, that is known as exophthalmos. Okay. So these are few important symptoms to compare hypo versus hyperthyroidism. Now a brief treatment guideline for hypothyroidism. If I want to treat a patient with hypothyroidism, I treat him with a drug very often, that is levothyroxine. Levothyroxine is very comfortably used in a dose of 1.6 microgram per kilogram per day. So the dose of microgram per kg per day is to be remembered about. So if you've seen any time any levothyroxine tablet in your ward or OPD, it is in microgram. It is not in gram, it is not in milligram, it is always in mcg, microgram. And the dose that you need to start the patient is 1.6 microgram per kg per day. Now you start your therapy, but you need to remember you decrease the dose of levothyroxine in one group of patient. One who is having a heart disorder, ischemic heart disease, and a patient who is elderly. Because in the All India exam, somewhere in 2011 AIMS pattern, they asked this question that in a patient you see MI, and with MI you diagnose him with hypothyroidism. Do you start the levothyroxine at the same dose, higher dose, lesser dose? I started with a lesser dose. Okay, I started with a lesser dose. In ischemic heart disease, if you give levothyroxine at the normal dose, it can cause palpitation, sweating and all, problem with the patient. So don't do that thing. So start your dose at a lower phase. Now you maintain the therapy with levothyroxine and you check something, TSH. Not after 1 or 2 weeks, after a gap of almost 1.5 months, after 6 weeks time. Normal TSH, I remember, ranges between 0.35 to 5 international unit per ml. That is a normal TSH level. The target TSH that we know is somewhere 2.5. So it should be somewhere midway. Can be less than 2.5 up till 3.35, but it should not be 7.6 at all. It should not be 4.5. Now the target is 2.5. Sometimes in clinical practice I start the therapy with per kg. If I don't achieve the TSH target of 2.5, I keep on increasing the dose by 25 microgram, 25 microgram. So something is not very strict, the per kg formula. Okay, we need to replace the thyroxine till the target of TSH 2.5 is achieved in the patient. There's one more disorder which came into limelight this season, was this subclinical hypothyroidism. The word is hypothyroidism, but the word is subclinical. All the clinical symptoms don't appear, minimal some symptoms will appear, subclinical. To biochemically define these patients, they are having a high TSH, yes. And if I look at their free T3 and a free T4 level, it is actually on a lower side. They are found to be low normal. So subclinical hypothyroidism patient have got a high TSH and a low normal T3 and T4. Treatment. For such a patient, the book recommends if the TSH is more than 10, then start your therapy with levothyroxine. If the TSH is in a range of 5 to 10, that's the gray area. In that case, you start with levothyroxine. If the patient is having TPO antibody positive, thyroid peroxidase antibodies are formed in inflammation. Patient might have got thyroiditis that has killed the thyroid gland, and the story is subclinical. Okay. Another reason why to start therapy is in a female, if they're coming to me with infertility or if they are pregnant. So in pregnancy, what I was mentioning, that the TSH rises and the T3, T4 dips down, maternal hypothyroidism very often presents with a TSH between 5 to 10 with a low normal T3 and T4 level. So in that patient, you always start your levothyroxine therapy for one good reason. If you leave the mother untreated, you leave the fetus also untreated inside. And the child which is born to a hypothyroid female can also be hypothyroid, cretinism. So that can be a blunder with the patient and the fetus inside. So subclinical hypothyroidism, TSH more than 10, give levothyroxine. If it is between 5 to 10, if the TPO antibodies are positive, then you start. In a female, if she is suffering with infertility and pregnancy, in that situation you start your therapy. Last two things in this chapter of thyroid disorders that you'll again read in your surgery classes. One of them is Jod-Basedow effect. They found that a patient used to come with a iodine deficiency. So some patient had got a low iodine in the diet. They are eating the food on the rock salt, or possibly from a hilly region they are consuming water that is again no iodine at all. So they are not exposed to iodine. They have a low iodine exposure in their diet, in their food for a very long time. But once they start eating iodine supplement, the story is 1 and 1, 11. They found when the iodine supplements goes to a patient who has been on a low iodine diet for a very long time, it actually increases the organification. As a result, T3 increases, T4 increases, and my patient at the end of the day ends up having hyperthyroidism. Because one of the common question that we faced was most common cause of hypothyroidism is iodine deficiency, one of the causes. So low iodine, hypothyroid, but this time low iodine, sudden iodine, increased organification, patient turns itself to hyperthyroid. That is known as Jod-Basedow effect. Other way around, Wolff-Chaikoff effect. In Wolff-Chaikoff effect, I increase the iodine exposure for the patient for a short duration. I think that T4 and T3 is all from iodine. So more iodine, more T4, more T3, no. Ulta, more iodine for a short duration would inhibit the conversion of T4 to T3, the conversion of inactive to active form. that will result in hypothyroidism. So 1 and 1 became 0 this time, or became -1 actually. So I gave more iodine to a patient for a shorter duration that inhibited the T4 to T3 conversion. I have already told 5-deiodinase, and that result in a decrease in the active form, and the patient behaves as hypothyroidism. That is a very famous term, Wolff-Chaikoff effect. So just look at the end result. If it is hyper, it is Jod-Basedow. If it is hypo, it is Wolff-Chaikoff. Write a question on this. A very interesting question. Again, a controversy in your guide. A 17-year-old girl was evaluated for short height. She has got an enlarged pituitary gland. Her T4 is low, her TSH is high. What's the diagnosis? Option A, pituitary adenoma. Option B, TSH secreting pituitary tumor. Thyroid target receptor insensitivity. Option D, primary hypothyroidism. Now I have a patient who has got an enlarged pituitary gland. Her T4 is low, her TSH is high. What is the answer? Why it is an answer is all in front of you. Controversy, I know. If the T4 is low and TSH is high, I believe the thyroid hormone is not found in the gland. Hypothyroidism, which I remember as primary hypothyroidism. So the answer is D. Why it is an answer is all in front of you. Why not the other people around? If at all the patient had a pituitary adenoma, what would be the problem? She will have a high TSH and she will also have a high T4. Her TSH and T4 both will be high, not high and low. Okay, so unlikely to be A. And A and B are the same thing. TSH secreting pituitary tumor means A only, pituitary adenoma. What is this? Thyroid target receptor insensitivity. We found in clinical practice some patients who are exhibiting hypothyroidism. Why? Because the T4 and T3 could not act on the peripheral tissue. So there was a resistance of T4 and T3 on the peripheral tissue, maybe heart, brain, anywhere. As a result, what happened? T4 and T3 level went up and it created a negative feedback and the TSH went down. So patients with thyroid target receptor insensitivity have got a high T4, high T3 and a low TSH. But then the question is just the reverse. T4 is low and TSH is high. So it cannot be C. Best answer is D. Someone had asked me that day, so this enlarged pituitary funda is to confuse us. No, it is a genuine problem. If the thyroid gland is not working, T4 is not getting produced, who is shouting? Pituitary gland. So enlarged pituitary doesn't mean an adenoma, it means hyperplasia also. So TSH high, pituitary hyperplasia, enlarged pituitary. So the best answer I found was D, primary hypothyroidism. Now we'll connect everything. How is the big boss connected to the pituitary gland? This is the last ball. Okay, class will end after this. Don't worry. Hypothalamus is connected to the pituitary gland with a narrow gully that is known as pituitary stalk. We divide the pituitary gland into two halves, the anterior and the posterior pituitary. The anterior pituitary produces TSH. Hypothalamus helps so that it produces TRH. Anterior pituitary produces ACTH. Hypothalamus produces CRH. Anterior pituitary also produces something for the female, FSH and LH, and hypothalamus produces GnRH, stimulation. Anterior pituitary also produces prolactin. For that, inhibition comes down, already mentioned in the initial beginning, that is dopamine. Regarding ADH, ADH is not produced in the posterior pituitary. It is just stored in the posterior pituitary. A old physiology question. ADH is produced in hypothalamus. It is only stored in the posterior pituitary. Whenever dehydration occurs, it comes out from the posterior pituitary and helps me out. Okay. Now there is a lesion between the connection. The connection between the two was stalk. So there is a lesion in the pituitary stalk. What will occur? Let's see that. Now if the patient is having a lesion in the connection pituitary stalk, what will happen? No TRH, no TSH, hypothyroidism. No ACT, no CRH, no ACTH, no cortisol, no blood pressure, hypoglycemia, hypertension. No dopamine, more prolactin, hyperprolactinemia. Tell me one thing, will the patient have DI or will the patient have SIADH? In a pituitary stalk lesion, A or B, DI or more ADH? Always DI, because the hypothalamus cannot just shift out the ADH directly from there. It has to come through this God-given route, stalk lesion. So if there is a stalk lesion, patient will have DI. Better word to define DI would be deficiency of DI, which we know as central DI. Okay. Note down a question on this. Something again, problem in your guide. A patient meets with an accident with resultant transaction in the pituitary stalk. Okay, which will not occur. What will not occur in the patient? What is not seen in the patient? I'll give you option A as diabetes, option B as diabetes insipidus, option C as hyperprolactinemia, and option D as hypothyroidism. Tell me an answer for this one. Diabetes mellitus, insipidus, hyperprolactinemia, or hypo? A quick answer, diabetes, because hypoglycemia will occur, not hyper. Answer is A, simple. But one of the guide gives option C to confuse you as SIADH. Now what is the answer? DM or SIADH? Double dip. Slow in answer. Difficult question. So that was an easy and this is the difficult question now. Oh God, see. I got this question, this thing in AIMS. In AIMS don't have to put the correct but the most appropriate answer. Okay. Oh, because diabetes is not specified in mellitus. What is this Allahabad center? It's not specified as mellitus. Dekho, one thing which I taught you that head injury patients come initially with more ADH, SIADH. After few weeks and months they develop DI. Okay. Now the question is that he met with an accident with the resultant transaction of the stock. It can be SIADH initially and then convert itself into DI. So SIADH can occur in initial stages of any head trauma, yes, but diabetes mellitus I believe will never occur. There is no hyperglycemia which initially is or later seen in the patient. Okay. So the answer is A all the time. Even SIADH can occur in a head injury patient. That's one reason for that. Now there is a similar kind of a disorder in which the pituitary gland is totally destroyed, which we remember as a term pituitary apoplexy. Death of the pituitary gland. Death of the pituitary gland can occur in a female population postpartum necrosis due to hypertension, which we very well know as a syndrome, Sheehan syndrome, and something from medicine which we know as a sickle cell disease. Sickling phenomena can cause infarct, sickle cell anemia, sickle cell disease. That can create an infarct in the sella turcica and can kill the pituitary gland. Patient can get pituitary apoplexy. Okay. This story of pituitary apoplexy was very often seen or associated or predisposed in patients who are already diabetic and hypertensive. So DM and ST are neither the cause, neither the effect. They are just a predisposing factor. Okay. When a pituitary apoplexy occurs, the first hormone that goes off is growth hormone. Second is luteinizing. Third is TSH. And the last is ACTH, GLTA. That's a very well-known mnemonic for that. Now I'll give you one gynae question on this. Again given wrong in your guide. That which hormone is replaced first in a female with Sheehan syndrome? I'll give you options for that. Option A, growth hormone. Option B, luteinizing hormone. Option C, thyroid hormone. Option D, cortisol. Which hormone is replaced first for a female who suffers with Sheehan syndrome? Rhythm correct, I believe. We understand that growth hormone may go up first, but no one dies of growth hormone deficiency. Everyone will die of hypertension, hypoglycemia, cortisol deficiency. You cannot easily replace the ACTH, but you can replace the cortisol by a steroid tablet or an injection, hydrocort, Addisonian crisis kind of a story, you know. So it is always important to replace the life-saving first. Don't think that the growth hormone goes and after 1 month the ACTH will go. No, it will all go within a minute or two. So it is a very rapid progressive kind of a thing. First, although molecularly growth hormone, the last is ACTH, but first always replacement with the life-saving, that is cortisol. So the answer is this. Okay, that completes our extensive discussion on endocrine. I may be falling short on discussion of thyroid and parathyroid, but I would like to acknowledge you on that because these two topics are more important from surgery point of view, not from medicine point of view. And a topic which I left behind was pheochromocytoma and Men's syndrome, again something from surgery. Okay, you can read it there. Earliest symptom of Parkinsonism is tremor, sickle cell disease, sickling, sickle cell anemia, sickling in the will. Etiology of SIADH is something that is raised ICT, head injury, and there are many malignancies that can cause this SIADH. Latent organ onset diabetes in young, LADA. That is something the diabetic patient who is ranging from an age of 20 to 30, who is pre-diabetic can get diabetic. So that is not a very good term that we remember LADA, but cutoff value for TSH to call hyper and hyper. See, lower limit was 0.35. If it is less than 0.35, it is hyper. If it is more than 5.5 or 5, it is hypo. Okay. Hyperthyroidism to a very severe extent is known as thyrotoxicosis. Okay. Extended fasting means you don't tell the patient to remain without food for 8 hours. Normally you and me don't eat for 8 hours. That is normal fasting. We don't go with hypoglycemia. You tell the patient to go for a fasting diet. You don't tell the patient to eat anything at all for maybe 3 days. As soon as the patient develops hypoglycemia, you check the sugar, you correct the sugar, but at the same time you draw the C-peptide insulin sample also. So the word is extended fasting, that is beyond 8 hours. Shelf life of insulin at room temperature, no idea. Need to check it from pharma. HOHA can be used in type 1 diabetes. I'll check on this. There was an MCQ in pharma about it. Okay, I'll check on this and let you know later. Which book to read for medicine? Harrison. Reading Harrison is tough. Reading a guide is always easy, and reading the note is very easy. But there are two guides of medicine. One is AA and one is MK, Mudit Khanna. I found Mudit Khanna to be more genuine a book for one reason. Questions and answers are correct with the authentic reference. AA, confabulation. Question is wrong, answer is wrong, and suddenly everything explanation wise also goes wrong. So I found a lot of errors in AA. They're trying to improve over the next few years, but MK is much better. Addisonium implementation order to accept, it involves the oral mucosa. It does not involve oral mucosa is wrong. Okay. See, AA recent edition and old edition doesn't have much of a difference. Some 10-15 MCQs only. Okay, because the question bank of All India, that is NB one-liner pattern as well as DNB, cannot be officially published. So that's a major drawback. Whatever the question keeps on adding is from AIMS. So AIMS questions in medicine are over the period of time is coming down. Okay, I'll show the slide. So thank you. Thanks a lot.